delivering babies painlessly, relieving pain, and saving lives.
Childbirth is said to be a highly joyful experience and is universally celebrated event. Childbirth, however, is a painful experience for a majority of women, and analgesia is regularly required for relieving pain. Exceptionally, very few women may have higher thresholds for pain. Others can control the responses to reduce pain. Most women think that pain is going to be a major part of giving birth. Each labor has a personal seal for each woman. For religious, cultural, and philosophical reasons, many groups have sought not to prevent or treat pain. Pain may have adverse effects on both the mother and fetus. The psychological effects to serve severe pain should not be overlooked, particularly when it is associated with adverse fatal maternal outcomes. Childbirth is an emotional experience for a woman and her family. Labor is a life event characterized by tremendous physiological and psychological changes that require major behavioral adjustment in a very short period of time. The mother needs to bond with the new baby as early as possible. Maternal satisfaction has to be taken into consideration while evaluating and quality and planning the maternal child healthcare services. Fear and apprehension are experienced alongside excitement. Their emotions, both positive and negative, will affect the woman's birth experience.
Today, sublime topic of learning is obstetric anesthesia of great importance. Enhancements in neuralgias, labor analysis techniques, postpartum neuralgias, pain management modalities, and prevention of intraoperative hypertension during cesarean delivery of intraoperative has improved our care. Progress is made in many areas, including questions about acute postpartum pain and its potential influence on chronic pain. The influence of labor pain, the perinatal depression, labor epidural associated fever, and the impact of labor analgesia during the second stage of labor and instrumental vaginal delivery. Current and future scientific works on individual physiological characters of pain, labor progress, and the other aspects of obstetric care may enhance clinicians' ability to personalize the obstetric anesthesia therapies and interventions. Comparing the effectiveness of studies, diagnosis and treatment modalities of pain during labor, the puerperium, the progress of labor, and the obstetric hemorrhage, as well as the effects of these modalities on patient-centered outcome, are necessary as our discipline advances further into the 21st century. Let's give glory to the Almighty God for making today's occasion a resounding one. Ganesha is the first sound, form in which all times were born. He perceived all women as veritable manifestations of his mother. So, motherhood is a divine event. With his blessings and grace, I call upon Dr. Sanjana to start the auspicious function with a devotional song of Lord Ganesha.
Good morning, everyone. गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलध्यायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यदलक्षेत्रे गुरुधर्म सदाराध्याय गुरुपुत्र पवित्रात्रे गुरुखण्डखण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि श्रीगणेशाय धीमहि श्रीगणेशाय धीमहि. Thank you.
Now I call upon the main instrumental person, organizing secretary, who has worked day and night for the CME away from its comfort zone. I welcome Dr. Shivanand sir to greet the gathering.
Thank you, Divya. Knowledge has beginning, but no end. The day you stop seeking knowledge is the day you stop growing. With this positive note, I wish you all a very good morning, one and all. Continuing medical education is an opportunity for us to refresh our knowledge, skills, and learn newer developments that continue to occur in our specialty. Obstetric anesthesia was born in 1847 when James N. Simpson of Scotland, an obstetrician, introduced open drop labor anesthesia. The acceptance of labor anesthesia was not easy as it is confronted religious misbelief, social and medical opposition. Today, obstetric anesthesia as a subspecialty of anesthesia has evolved from facilitation of cesarean deliveries to labor anesthesia for both complicated and uncomplicated pregnancies. Obstetric anesthesia is a demanding and emerging branch which tests our senses, preparedness, and our capabilities as an anesthesiologist. We faced intriguing situations during the recent pandemic where our experiences were put to a trial, and I must admit that we were not fully prepared and well equipped. The purpose of such CMEs is to prepare ourselves to address such problems and update our knowledge. On behalf of Department of Anesthesiology, BLDE Shri BM Patil Medical College, and association with the ISS City Branch, Vijayapura, I welcome you all for the today's CME on obstetric anesthesia. I take this opportunity to welcome wholeheartedly our Honorable Vice Chancellor, Dr. R.S. Mudal sir of esteemed university, who has spared his valuable time to be with us today. Without sir's kind cooperation, this CME would not have been materialized. I welcome you, sir. I welcome our beloved head of department, Dr. Patil madam. Without madam constant support and guidance, this CME would not have been possible. I welcome you, ma'am. I welcome Dr. Vijayapura sir, the present president of ISA Vijayapura and former medical superintendent of the college. I welcome you, sir. I also heartily welcome our distinguished speaker, Dr. Sarojini Jagdish, who is a renowned teacher. He is a consultant anesthesiologist and a senior clinical lecturer in the University of Western Australia. I welcome you, ma'am. I also welcome Dr. Ravindra US, who is a stalwart in area management, and sir is very passionate about anesthesia. Sir is a consultant anesthesiologist, Jirudanga Park Medical Center, Brunei at Dar es Salaam. I welcome you, sir. I also welcome Dr. Madhuri Kudi madam, who is an able academician and administrator. Madam is presently working as a professor and head of department in KIMS Hubli. I welcome you, ma'am. I welcome Dr. Sripal Mahendra sir, who is a mentor and external board of studies member of our department. Sir is currently working as a professor and head of department at Shema Daralkatte, Mangaluru. I welcome you, sir. I also welcome my dear colleague, who is very passionate about obstetric anesthesia, Dr. Vijay Katti, Associate Professor, Department of Anesthesiology. I welcome you, sir. I wholeheartedly welcome Dr. Uday Kumar sir Nucci, Professor in the Department of Forensic Medicine, and also today's KMC observer for our CME. I welcome you, sir. I also welcome Dr. Rajendra Kumar sir, Head of Department of Parliament Medical College, Vijayapura, and Dr. Pandit sir, who is a renowned private practitioner. I also welcome Dr. Rekha Mudul madam, who is a professor in Department of Ophthalmology for CME. Last but not the least, I welcome all the delegates who has registered for today's CME, my dear colleagues, postgraduate students and friends, and all technical and supportive staff. I am very confident that this CME will be an academic feast and it will be enlightened with knowledge by our renowned speakers. Thank you.
Thank you, sir. Light is a revered universal symbol of truth, knowledge, and understanding. It acts as a guide, keeping us from stumbling in the darkness. The lamp also shows everyone how to rise upwards and dispel darkness. After all, fire is one of the 5 elements that form our body. On behalf of Department of Anesthesiology, I call upon all the dignitaries to light the diya on this propitious occasion.
These beautiful flowers remind us the glory of the God and the wonders He has created. I would like to call upon Dr. Patil sir to hand over the beautiful flower to our beloved Vice Chancellor, R.S. Madhuval sir, as a token of gratitude and respect.
Now I would like to call upon Dr. Priya to hand over these beautiful flowers to our beloved HOD, Dr. Vijayapura ma'am.
Now I call upon Dr. Nirmal Kumar to hand over these beautiful flowers to the organizing chairman of the CME, Dr. Vijay Kumar sir.
Now I call upon Dr. Priyanka Verma to hand over this flower to our KMC observer, Dr. Uday Kumar Nucci sir, who has been very supportive and has guided us in organizing this event.
Now I call upon Dr. Sardinia to hand over these flowers to the organizing secretary of the CME, Dr. Shivanand sir. welcome the young, energetic, and the charming person of our department, Dr. Anusha, ma'am, to speak a few words on our Vice Chancellor, R.S. Mudwal, sir.
Thank you, Jofi. Good morning, everyone. It's my absolute privilege to introduce our chief guest to today's CME, our beloved Vice Chancellor, Professor Dr. R.S. Mudwal, sir, on behalf of Department of Anesthesiology, BLDE deemed to be University, Shri Patil Medical College, Vijayapura. Sir was born on 1st of June 1956. Sir has completed his MBBS from Karnataka Medical College, Hubli in 1981, followed by Diploma in Otolaryngology at JNMC, Belgavi in 1984. Later, Sir obtained his MS degree from Karnataka Medical College, Hubli in 1987. Sir also holds an MBA degree in Hospital Administration from Annamalai University, Tamil Nadu. Sir has an exemplary career spanning over 35 years of great achievements in academic, administrative, institution building, as well as charitable works. Probably, it would take a whole day to mention all those achievements. So, I'll try my best to give a brief introduction of these great personalities whom we all admire. Sir joined as a lecturer in Department of ENT, JNMC, Belgavi in 1987. Sir became professor in the year 2002 and also served as medical superintendent at Delhi Medical College Hospital. Sir headed the Department of ENT as HOD from 2010. Sir held the position of Vice Principal from 2015. Later, Sir became Dean Faculty of Medicine from 2019 at Jain Medical College, Belgavi. Sir joined as Vice Chancellor at BLDE University from February 2021. Later, Sir was in charge Vice Chancellor at the BLDE University from May 2021. Now, Sir is serving as Vice Chancellor of BLDE University from July 2021. During his illustrious career, Sir has been part of many medical research projects and publications. Sir was guide for 8 PhD scholars and was guide for more than 25 ENT postgraduate dissertations. Sir was part of various guest lectures, orations, and resource person at international, national, and regional conferences, CME, and workshops. Sir organized more than 30 conferences, CMEs, and workshops. Sir has also published a chapter titled Ossiculoplasty in the ENT textbook. Sir has more than 50 paper publications at various international, national, and regional journals. Sir has held various important university, academic, and administrative positions at RGHS, Delhi University, Goa University, and BLD University. Various awards and laureates followed for outstanding academic and administrative achievements of Sir. To mention a few, Sir was awarded Honorary Fellow, Karnataka Science and Technology Academy, DST, Government of Karnataka in September 2021. Sir was entitled as Best Teacher Award by Kannada Balga in 2013. Sir was also granted Teacher of Teachers Award by KLE University on September 5, 2015. Sir was felicitated by KLE Society on 102nd Foundation Day 2017 for his exemplary work done by organizing and conducting free health camps. During Sir's tenure at KLE Hospital, KLE's Dr. Prabhakar Kore Hospital was ranked 14th in the top 15 best hospitals in India in 2018. Sir was nominated for Rose of Paracelsus Award at Oxford, UK in the year 2019. And the same year, Sir was also nominated for European Award at Cannes, France. Sir was invited as a guest faculty at various international conferences across the world. Sir was invited for charity work to Kenya to provide free health services to the poor and needy persons, in which more than 15,000 patients were examined and more than 5,000 surgeries were performed in the year 2013. Sir was felicitated at various international conferences, CMEs throughout his career. Sir was instrumental and played a major role in the establishment of KL is Dr. Prabhakar Kore Charitable Hospital, Belgavi. And sir was the first medical superintendent of Dr. Prabhakar Kore Charitable Hospital at Belgavi. Sir was the organizing chairman for the centenary free mega health camp checkup. Sir started the collaboration with Vijayapura Care Center, Bangalore, along with the JNMC Belgavi. Sir was the officer in charge and academic collaboration with Cosse Ear Clinic, France in 2008. Sir has also coordinated Lyon connectivity of life surgery from France to the Department of ENT JNMC since 2008. Under the supervision of Sir, there was establishment of cadaveric skill lab at JNMC in 2018. It's my honor and privilege to welcome Professor Dr. R.S. Mudol sir, a great teacher, academician, staunch administrator and institution builder for this CM. We all welcome you, sir. Welcome. Sir.
Now I call upon our Honorable Vice Chancellor, the R.S. Mudol sir, to speak a few words.
Very good morning to one and all. The outset, I congratulate the Department of Anesthesiology choosing the very apt topic and need of the day, Cme In Obstetric Anaesthesiology. And guest they have chosen is Dr. Sarojini, Ravindra, Madhuri, Sripad, Vijay, all stalwarts in the anesthesia. I know Dr. Sarojini, she was a staff member in JNMC, and I have met her when I visited Australia also. They are doing very well and very protocol based there. So those people will be very helpful for our CME as a resource person. And Dr. Vijay Kumar, Madam Vidya Patil, and Shivanand, they have worked hard to have this CME and very focused CME. And Dr. Uday Kumar is here as a KMC observer. And our friends, Dr. Pandit, who was my senior, MS Brother, sir, classmate, Idri Madam, Rajeshwari Madam, Aruna, Dr. Rekha, Dr. Lakshmi, all other anesthesia staff members and dear postgraduates. These CMEs are very, very important. Time to time, remind our development in the subject. This is one of the department where is very technology driven today. Technology driven, and lot of technology has come into how you have to interface between the technology and the clinical service, what is required. That is very important for all the anesthesiologists to update yourself. And we are happy that they have taken all very good, you can say in anesthesia, BMW, that is regular anesthesia machine. They have taken 6. That will help them to give the very complicated cases. And batch of 6 machines they have taken, and state-of-art sonography, the regional anesthesia they have taken. Whatever they have asked, and they are utilizing it. That is very important. And today, you know that pregnancies are very, very important. Shailaja Madam has to, Aruna has to agree with us all. First of all, pregnancy has become in this rat race world has become very difficult. And that conceiving itself has become challenge for the working class. And after conceiving, you know that you have to have anesthesia planning, ANC, then where to deliver, what is the status, what is the sonography, whether premature, all those things. And every one, the delivery, one mother is born and a new one is born. To help both of them, the very important role is anesthetist, as is important obstetrician and important anesthesia. We have to understand today it is a conventional anesthesia, just give them the intubation and give this some sort of relaxation anesthesia. It's not that. Now you have to think of premature baby is coming and section is, and now many times the premature babies are born. How best you can give the what anesthesia you give, and you have to plan with that, with the obstetrician. And I really congratulate you, madam, choosing the very apt topic that anesthesia in obstetrics, the CME on that, and all the stalwarts are being called. And now most of the anesthesia departments are empowered with the lady staff. Because I have seen in other medical colleges also, a lot of, as OBG was the only thing, the department filled with the lady staff members. Today, if you see many of the anesthesia departments, many ladies are there in the anesthesia. And all of the male partners have to agree that ladies are very meticulous. And if you see now bouquets also, you have to understand that if a lady is heading a department, what meticulousness can happen. So that's what we see the same thing now. Shailaja Bidri madam has taken the reins of the department. I hope under her leadership, the OBG department will shine. And we are making that is one of the best department to our center of excellence. Along with now the dermatology has become now pediatrics, and we are looking at OBG to have good MCH ward. To have that, Vidya madam already have told that many times MCI people are asking how many units you have got. And I think she has got idea that 4 units or 5 units she will make. 1 unit is OBG unit, OBG anesthesia, other one is trauma anesthesia, other one is surgical anesthesia, and ENT ophthalmology anesthesia, like that. And today you have to remember, anesthetists have become very important integral part of the emergency care. And MCI also tells, and the fortunate that we are having already emergency medicine. And the brother sir, we have to, all his ideas, we have to salute him that he has planned such a way that, and with Dr. Arvind Patil, emergency medicine, many old medical colleges are not having 3 MD, they are already having. Geriatric medicine, many colleges are not having, already 2 MD they are having. So planning is very well, and whatever he has planned is my duty just to take across the next 4 years or whatever I can do. His all dreams can come true. I would be the most successful in inculcating all his academics, his ideas, many of you have to agree that how good teacher he was, how good administrator, more than that, how good human being he was. If we can move in his path, that would be biggest tribute we can give to brother sir. And all of us, all of the teachers are very happy and compassionate. You give little to the patients, patients would be more happy. And the 2 things we have to see always, that our PG should be happy, undergraduates should be taught, PG should be trained, and our patients should be happy. These 2 factors, morning 3 hours and evening 2 hours if you can do, and rest of the hours are with you. I think that would be a great thing that we can do to the management is very. MP Patil sir has given free hand to us. It doesn't mean that they are not observing us. They are all observing us, that we have to do our best to the institute, and that would go in a long way to develop the things. And after 2 years of pandemic, I think offline we are all meeting, even though it's a hybrid mode of the things, many people who cannot, we have to continue hybrid mode, because many of the stalwarts who can bring on the platform. That's one thing. Many can log in and they can get the knowledge. Knowledge is not just we can have ourselves, you have to spread it. And the aim of the medical college, spread to the knowledge to the as many people as you can. That should be the thing. And bring the stalwarts to the platform, that knowledge will be shared. And now anesthesia is not only just knowledge, it has become very skill-based, technical-based, and it has to be very well updated. And these CMEs and conferences are the ways to update ourselves and to know what is happening in the other part of the world also. With that note, I think I congratulate the Department of Anesthesiology, who have planned it very focused area of anesthesia subspecialty. And I hope that Madam will take the subspecialty for the fellowship programs also. Our own staff members who join as SR, simultaneously you give them fellowship. You need not have to call from outside. And once it is a vibrant course, definitely the people will simultaneously, SR is there, you give them fellowship also. They will be armed, double armed. One is fellowship focused area they will work, and also they will work for 1 year. And when they become assistant professors, they are having already one fellowship and the required knowledge also. That's how all the department has to take a cue that subspecialty, you have to simultaneously train your the SRs or the tutors, whatever, you give them opportunity to work as a fellowship programs. And with that, I think I once again congratulate you. That very good apt topic you have taken, and hope that the today's function will be knowledge sharing, which is technology based also. And next time you can have hands-on training, all those things. And, I congratulate and wish you all the best and very successful CME of this sub-specialty. Thank you, one and all.
Thank you, sir. Now I call upon the most disciplined and dynamic person of our department, Dr. Vijayapura, sir, to do the presidential remarks.
Good morning, everyone gathered here. Respected dignitaries, Honorable Vice Chancellor, Sir, Dr. Mudro, and our HOD, Vidya Madam, and KMC Coordinator, Uday Kumar Nuchi, and my friend, Organizing Secretary, Shivanand, and senior faculty of OBG, and my colleagues, and other department colleagues, and postgraduate students. So, this theme of this obstetric anesthesia, why I have chosen is, there are so many, this is obstetric anesthesia can be challenging. So it can, anything can happen. So many CMEs, lecturers happens, but every time you have to unearth the problems and solve the problems and you get the new ideas. So such CMEs will be very helpful. And this melodious invocation song by this Lord Ganesha's song, and encourage and guidance from Dr. Mudro sir. So this academic fest will be, I hope, sure it gives the fruitful knowledge to our postgraduates and colleagues. And we have eminent speakers from Karnataka and abroad, Dr. Moody, Dr. Kudi Madam, and Dr. Ravindra, and Dr. from our faculty, Dr. Vijay Katti, and one more from Mangalore, Dr. Shripa. So I am very thankful for them, and also I am very thankful to management and Chancellor sir, and BLDE University, and Dean faculty, and our colleagues, department colleagues, and postgraduates is making this CME. Conducting this CME. And one more thing, we had more than 150 registration. That indeed a great applause to my colleagues and my postgraduates. So once again, I thank everyone who helped in conducting this CME. Thank you.
All is well that ends well. Finally, I leave you the inspiring quote of Henry Ford. Coming together is the beginning, keeping together is the progress, and working together is success.
With a lot of appreciation and gratitude who made this event a grand success. With a positive note of many more programs we will celebrate together ahead, I call upon Dr. Rahul Shalkere to propose the vote of thanks.
Good morning, all. Thank you is a powerful word that cannot be seen or touched. It must be felt by heart. It's not the happy people who are thankful, it's the thankful people who are happy. With a positive note of many more programs to follow, I feel honored and privileged to get the opportunity to propose a vote of thanks on this special occasion. First and foremost, let me thank the Almighty God for making this occasion a grand success. I would like to thank all the honorable guests who blessed us with their presence. I'm also thankful to all the program advisory committee members and the invited intellectual speakers. Words are not enough to thank their constant guidance and support to shape the conference. I, on behalf of organizing committee, convey my deep regards and hearty thanks to our Honorable Chief Patron, Dr. M.B. Patil. I also wholeheartedly thank our Vice Chancellor, Dr. R.S. Mudol, for his valuable time. Sir, your presence today is a great source of motivation to all. I am also thankful to our beloved principal, Dr. Arvind Patil, Dr. Arun Inamdar, Dr. S.P. Patil, Dr. J.G. Ambekar. They helped us with all the necessary administrative approval for organizing the event in our college. They supported in all the possible manner to organize this CME. My special thanks to speakers who are going to speak now for imparting their knowledge and experience and updating newer concepts. Today, my words are not enough to express the gratitude to Professor and HOD Dr. Vijay Patil, Dr. Shivanand Dalke, Organizing Secretary, and Organizing Chairman Dr. Vijay Kumar for their constant help and guidance that radiated a source of energy within us. I also thank all the speakers for throwing light on the latest trends and graciously accepting the invitation and consenting for today's speech. My heartfelt thanks to heads of various departments and faculties for their support and understanding. We will ever remain grateful to you and we thank you for being with us today. I am very much thankful to all the faculty colleagues and non-teaching staff members who always stood by us and motivated us. I feel proud and thankful for making this event a successful one. We have been fortunate enough to be backed by a team of very motivated and dedicated students. I cannot thank everyone enough for the involvement they have shown and the willingness they have expressed to take on the completion of tasks beyond their comfort zones. It would have been impossible to organize it without their support. Thank you very much again. At the end, I would like to take this opportunity to thank the IT sector who joined hands to organize the dream this CME. And time is money, and then today you have spent millions for us. Thanks to all of you for striving hard in making this event a resounding success. We are all honored by your presence. Thank you for listening.
Now we start our session.
Very certain. Very certain. Yes. Yes. Hello, chair.
Initially, our CME was scheduled to be on 13th of this month. Due to inevitable reasons, we had to prepone it today. It is not possible for Dr. Sarojini Jagdish to be physically there online for our talks and answer the queries. We have a recorded talk.
Now I call upon Dr. Renuga, Associate Professor, Department of Anesthesiology of our institution, to chair a scientific session by Dr. Sarojini Jagdish on the topic labor analgesia.
Good morning, everyone. We'll begin with our scientific sessions. The first talk is by Dr. Sarojini Jagdish. She is now working in Australia. She began her journey as a medico from KMC way back in 1985. Then she went on to do her post-graduation from JNMC Belgavi, where she was the university topper. Then, after working for a few years at JNMC Belgavi as assistant professor, she shifted to Australia, where she is now registered with the Australian Medical Board. She is also a fellow of the Australian and New Zealand College of Anesthesiologists. She is a consultant anesthesiologist at the Armadale Kalamata Health University. She is in charge of the training programs of the anesthetists appearing for the FANSTA exams. She is also involved in the various clinical trials. To mention a few, the Enigma trial regarding nitrous oxide and ondansetron trial, that is the Oscar trial. She has various presentations in national and international conferences both in India and Australia. Her areas of interest are obstetric anesthesia, regional anesthesia, and acute pain. Now we'll start with the very interactive lecture by Dr. Sarojini Jagdish. Though it's a recorded lecture, I think it will be a very informative one. I request all of you to please concentrate and take maximum use of it.
Hello everyone. I am Sarojini Jagdish, consultant anesthetics. I bring greetings from Australia. At the outset, I would like to thank the organizers and my friend Vijayapura for giving me an opportunity to present on this topic. I will make on my experiences with labor analgesia in Australia. Labor pain, as expressed by many of the laboring women, supposed to be very severe. Untreated labor pain results in an undesired psychological and physiological consequences. Labor pain produces physiological changes with emotional distress and suffering. The stress response will be the release of stress hormone affecting the mother as well as the fetus. These stress response may not be of much significance in a fit and healthy baby, but the mother cardiopulmonary disease, and especially on the preeclampsia and eclampsia, and also the fetus at risk affected a lot. Pain induces hyperventilation, which can result in hypoxia, respiratory aneurysms. That causes the uterine vasoconstriction and increasing the classical perfusion. This also causes shift of oxyhemoglobin dissociation. Adequate analgesics can reverse the disease and disease. This is the response, stress response that presents in the lady. So labor pain and stress, which causes sympathetic stimulation, that increases the free fatty acids, hyperglycemia and metabolic acids, which can also cause fetal metabolic acids. Hyperventilation, respiratory aneurysms, causes uterine vasoconstriction, so that hypocardia causes uterine vasoconstriction, seeing the placental blood flow, resulting in uterine. This also causes shift of oxyhemoglobin dissociation toward the left, so which indicates that there is less release of oxygen from mother to the fetus. And also during labor, because of hypocardia, active episodes, which might get exacerbated by the concurrent administration of opioids and sedatives being made, resulting in maternal hypoxia, fetal hypoxia, and resultant fetal hypoxia. There are various means of providing analgesia. So these are some of the non-pharmacological measures for pain, which are not very critical. Other pharmacological means are use of opioids, systemic opioids, and also the gold standard is the Coagulation. With opioids can be prevented the muscular injection of morphine, methylene, or else can be given as a patient control intravenous anesthesia, which is of real use in patients where there is a contraindication for additional treatment. Internals should be almost, which is a combination of 50% of oxygen, 2% of nitrous oxide, which is beneficial in providing pain relief by to moderate. The gold standard techniques are epidural anesthesia, spinal, which can be single shot or continuous spinal, combined spinal epidural anesthesia, and also dural puncture epidural, which is a related new technique. And other lesion techniques are vagal nerve block and paracervical nerve blocks, which are not practiced. So, among traditional techniques, the commonly employed labor analgesics are internals, opioids, and also the dictionary. Transcutaneous electrical nerve stimulation as a weak enzyme work. Opioids predominantly act as sedatives and analgesics. The pain scores are minimally changed in the administration. Internals indications that fatigue, but complete analgesia is never achieved When initial analgesics are contraindicated, patient control, maintaining any technique of choice, analgesia. Here, administration of systemic analgesics is associated with sedation and respiratory depression. Some different support, right? Neurological damage, which may be temporary or permanent damage. The chances are very small. Then coming to the post-dural puncture headache, the risk of PDPH. When we explain to the mother of the risks, so the first thing we say is headache, post-dural puncture headache. The incidence of this PDPH is 1 in 100, 1 in 200. So that is why we need to make sure that we have not reached the dura, not entered into the subarachnoid space, so not, and making sure that we are not causing the post-dural puncture headache. Epidural abscess, again, which is another serious complication that can happen with epidural. So coming to the accidental dural puncture, we are performing the epidural. So my needle, instead of entering into the epidural space, it has accidentally landed in the subarachnoid space, which is very adjacent to it. What is the management, immediate management? One I can do, thread the catheter, the same epidural catheter, into the subarachnoid space and mark that catheter clearly as this is a subarachnoid catheter, because we don't want to inject the epidural dose of the local anesthetic into the subarachnoid space. You know what happens? So it can cause high spinal and total spinal, the volume of local anesthetic into the epidural volume into the subarachnoid space. So marking clearly as this is a subarachnoid catheter, and every top-up has to be done by the anesthetist. Here we don't ask the midwife to give any top-ups. So every time the patient requests, the anesthetist has to go and give the top-up. That's one option. The other option is pull out the epidural catheter and insert epidural in one space, go one space higher up and do another epidural. But again, you are carrying the risk of doing another puncture into the dura, causing subarachnoid block. So we have caused the dural puncture. When can mom present with the headache? The onset of headache is usually takes 20 minutes because the rate of loss of CSF needs to be more than the rate of formation of the CSF. So when the rate of loss is more than the formation, so that is when we get the headache. And this is typically the postural headache, which is frontal or occipital. And majority of the time they do complain of neck stiffness, photophobia, ringing in the ear, tinnitus, and they will be nauseous. When we go for the pain rounds following delivery, the mother says, please don't put on the light. I'm becoming sensitive to light. That's an indication. That will give an indication to me that probably she's having a headache. So what is the treatment? Conservative treatment. Initially, we need to do a conservative management. So it does respond to conservative treatment in up to 60 to 70% of the individuals. So this conservative management includes adequate hydration. If the mom is able to tolerate the fluids already, we encourage her to drink plenty of water. And also if she is happy to drink coffee and tea, the caffeinated drinks, when the Coke, which causes cerebral vasoconstriction, so we encourage them to have that. Along with that, we do provide analgesia, regular paracetamol, non-steroidals, and sometimes with tramadol and oxy analgesics. So we do wait for 48 hours to see whether this responds to the conservative management. If there is no response to conservative management, then the definitive treatment for this post-dural puncture headache is dural blood patch. So there are reports saying that if the blood patch is done less than 48 hours of delivery, the effectiveness of the blood patch is not that much. So we usually perform blood patch after 48 hours. And we also need to remember that while doing the blood patch, again there is a risk that we might puncture the dura. The epidural blood patch is done in aseptically in theatre with the 2 operators. We take out the one operator will get the blood aseptically, and the other operator will identify the epidural space and inject this blood into the epidural space until the mother feels fullness in the back or complains of some back pain. Usually, my experience, from our experience, we tend to use 20 to 25 ml of Patil. The patient's blood injected in the space. Once we do that, we see the instantaneous relief. So mother who was not able to open her eyes and see the light and not able to sit up, say that, oh, my headache is getting less. I can see the lights. I'm in the, okay. So I'm in the theater. This is the instant relief is because of the dura that is pushed with this blood. Instantly increases the intracranial pressure. So the post-dural puncture headache, it is a low pressure headache. So by pushing the dura, it instantaneously increases the pressure in the cranium. So there is a relief. The prolonged relief is the blood, the injected blood, it will clot and seal the hole that is formed in the dura. Sometimes we may not get adequate relief with one blood patch. We may have to repeat the blood patch. There are few instances where we have done radiological with a interventional radiologist identifying the site of the puncture and injecting. So because we were not able to seal the hole by blindly doing the blood patch. So the other dreaded complication I was talking to you was local anesthetic systemic toxicity. So which is again the preventable complication. In case if that happens, we need to follow the ALS 2 guidelines, cardiopulmonary resuscitation and advanced cardiac life support, along with the immediate administration of intralipid. 20% lipid emulsion is injected to facilitate the recovery. So intralipid will help to facilitate the recovery from cardiac arrest with the local anesthetic. So any major centers where they do the major regional techniques, every unit needs to have an intralipid available to treat local anesthetic toxicity if it happens. And we all know that bupivacaine is much more cardiotoxic than ropivacaine, and we are using bupivacaine most of the time for these epidural techniques. So we need to make sure that we have intralipid available to treat if this happens. And also immediate cardiac resuscitation following the advanced cardiac life support. So I did speak to you guys about the complications of epidural. Suppose the fit and young patient has epidural and delivers, she goes home. So after going home, as the incidence or the risk of post-dural puncture headache can happen 24 to 40%. This might happen after she is discharged also. Every laboring woman or every person who gets the spinal or epidural or CSE, so they do get this after spinal or epidural care, and educating them about looking for any headache, backache, or signs of any infection in the back, and also any numbness or weakness. If that happens, they need to contact us immediately or present to the emergency department so that they are recognized and addressed, treated. So we have done the epidural, and we need to know how the mom has gone. Was she happy with the epidural I have performed? So this is the audit form. When we see them following day with in the pain rounds, so we just fill up this form and later on the audit, how many complications, what was our success rate. So our rate of epidural here at Airway Hospital is 35 to 38%. Is our rate of epidural. The other regional techniques that are used during labor are combined spinal epidural. So which is used if the mom is very distressed in advanced stage of labor. So for the faster onset of action, we use this technique, combined spinal epidural. So initially identify the epidural space, that the spinal needle goes, spinal is done, and a very low dose of local anesthetic. Usually use 1 to 2 ml of the premix with some fentanyl, 10
micrograms of fentanyl. So the immediate relief, the pain, and then the epidural catheter is threaded. Subsequent to later. There is a newer technique, much spoken about, is the dural puncture epidural. It is similar to combined spinal epidural, but if we don't inject anything into the epidural space, it is just a confirmation that we are in the right route. So before entering into the subarachnoid space, we have to pass through the epidural space. So if we get a CSF, we are confirmed that we are in the right route and we are going to be in the epidural space. So it is a dural puncture epidural. That has also shown that it's a faster onset of analgesia. But one risk is we are puncturing the so the dural puncture for no purpose. So we are breaching the from this incidents. Coming to walking epidural. So up to 50% of the women who are laboring, they would like to have motor power. They want to mobilize during that. So this can be achieved with a weak concentration of local anesthetic and a small volume of the local. So they help in preserving the leg strength. And also we need to make sure that there is no impaired proprioception. So before we allow the mom to mobilize, we need to perform the straight leg rising test in the bed to confirm the motor power and also the bending of the knee, whether the mother feels that sensation of bend that is happening in the knees for the proprioception. And we need to have two assistants when the mother stands up for the first time. So this needs to be repeated with each topic. So the same sequence needs to be repeated with each topic, making sure that she has not lost her motor power and proprioception. Other regional techniques, the less practiced ones, are pudendal nerve blocks, paracervical nerve blocks. So pudendal and paracervical, we don't use them in our institution. So we have absolute contraindication for regional technique, but mom requests for pain relief. So the best pain relief next to in place of regional techniques is patient-controlled intravenous analgesia. So that is a continuous administration of administration of narcotics, short-acting and ultra-short-acting narcotics. So on few occasions, I have used patient-controlled intravenous analgesia with fentanyl. But in those instances, I need to inform the pediatrician that they need to be present at the time of delivery. Remifentanil PCI is much more in practice than fentanyl PCI because of its rapid onset of analgesia and also rapid onset and rapid offset. So it is ultra short duration, and we know that remifentanil is metabolized by the non-specific plasma and tissue esterases. But it is a potent respiratory depressant. So we need to be monitoring the respiratory rate, saturation, and the sedation scoring needs to be done. Continuous monitoring needs to be done. And 1:1 nursing care is indicated in these situations. The remifentanil dose used is 10 to 30 micrograms with 2 to 3 minutes of lockout. Fentanyl PCIA, where if we don't have remifentanil available, we can use the fentanyl PCIA. So this has the same risks like respiratory depression and sedation that can happen with fentanyl. So it has a rapid onset and relatively short duration. Fentanyl also doesn't have any active metabolites. The dose we use is 10 to 20 micrograms with each bolus and 5 minutes as a lockout. We do come across mothers with systemic diseases, cardiovascular disease, respiratory disease, or mom with any hypercoagulable states who are on anticoagulants, either clexane, warfarin, or antiplatelet agents. Suppose if the mother is on clexane, if she is on a prophylactic dose of clexane, we need to wait until 12 hours before we put in the epidural. With a therapeutic dose, it is 24 hours before we insert the needle. We need to be away from the drug. So we need to stop the drug 24 hours before we insert the epidural needle. And for the removal of the epidural catheters, it needs to be 12 hours before we need to stop the low molecular weight heparin. And the subsequent dose of clexane or low molecular weight heparin can be given 4 to 6 hours after the removal of the epidural catheter. For unfractionated heparin, the needle placement and removal is usually 4 hours after we discontinue the heparin for insertion and also for the removal after 4 hours of discontinuing the heparin. So do we do the platelet count routinely for all of the mother? No. The fit and a healthy mom who doesn't have any systemic diseases, routinely we don't do the platelet count. But on occasions, we do encounter mothers with low platelet counts, thrombocytopenia. So what is the level we are need to proceed with it? So these chances of the thrombocytopenia conditions, it may be of unknown etiology, may be of immune thrombocytopenia, gestational thrombocytopenia, and we know that patients with preeclampsia, eclampsia, and HELP syndrome, they will have a low platelet count. And they have a very labile platelet count in these patients. We do need a platelet count within 6 hours of insertion of within 6 hours before we insert the epidural. In all these situations, if the platelet counts are more than 70,000, we do ask for other coagulation tests like INR, and if they are not, it is normal, we go ahead with the platelet count more than 70,000 with other coagulation profile. So always in these situations, we need to weigh the risks and benefits of doing the epidural procedure, because we do know that we have alternative techniques that are available in order to avoid the risks. So additional coagulation tests needed may be advised, and we may need to avoid axial techniques in some of the situations. There are some myths regarding insertion of the epidural catheter, or epidural needle. At what stage? Initially, we used to say that only when the mother is in active labor, that is when the mother is a 3 to 4 centimeter dilated. Now, more and more studies. 2014 meta-analysis of 9 studies and other research has shown that there is no need to wait for any degree of dilatation. It is okay to proceed with the epidural insertion. So irrespective of the degree of the dilatation, if the mother requests for an epidural, it is our duty to provide analgesia. And also these studies have shown that there is no increased risk of cesarean delivery or the duration of the second stage of labor or the effect on fetal outcomes with the use of the epidural techniques. Another thing is maternal fever during epidural analgesia. There is also a controversy that labor epidural increases non-infectious maternal fever with no established exact mechanism. So this may result due to an alteration in the production and dissipation of heat resulting from the epidural analgesia. There is no difference in the incidence of fetal sepsis among neonates born from mothers who receive epidural and those who did not receive epidural. Now, what are the effects of this epidural analgesia on the neonate? Neonates breastfeeding. So there is less interference with neonatal feeding behaviors. So there are no obvious feeding behaviors that have been observed in patients receiving epidural analgesia. In the absence of maternal hypotension prior to delivery, urexal analgesia and anesthesia do not have any negative effect on the baby. So we do encounter ladies with scoliosis and more moms presenting with advanced age with previous spinal surgeries. Is it a contraindication for epidural? No. So previous spinal surgeries, it's not a contraindication for decision. But it will be a challenging one. Technically challenging. The procedure will be technically challenging. And there is a risk that we may end up with a patchy block, and use of ultrasound has made it much more beneficial in identifying the midline and also for the location of the hardware safely inside the epidural needle or the catheter in these ladies. Thank you all. This is the end of my presentation. If you have any queries or questions, please email me the questions to this address. I sincerely apologize for not being able to present through Zoom. Thank you once again. See you all. Bye.
Madam, Dr. Sarojini has elaborately explained regarding the techniques. He has shared a lot of troubleshooting during her vast experience with labor anesthesia. I hope all of you have gained a lot of knowledge regarding labor anesthesia. Thank you, madam. Thank you for your valuable time.
Thank you, ma'am. Now I call upon Dr. Vijayapura, our HOD, to hand over a certificate to Dr. Renuka for chairing the session.
Now, I call upon Dr. Dr. Rajendra Kumar, Professor and HOD of Alameen Medical College, Vijayapura, to chair scientific session by Madhuri Gurnia, Professor and HOD of KIMS Hubli of the Department of Anesthesiology on the topic critical care in obstetrics.
Videos.
Well, I'm audible. Thank you. I think madam is on.
Yes.
Thank you for the medical college for inviting me to share the session on this prestigious platform. And it's my great pleasure to be here to introduce one of the IT academic students, Dr. Madhuri Kulkarni, madam, professor and head of the department. It's a great pleasure to be part of this CME and introduce our madam. She is very popular teacher, speaker, leader, and she is known both nationally and internationally also through her publications, through her lectures, and she has been very active in her local city branch. She has got so many awards and achievements which runs into pages. Here I cannot describe all the achievements. It takes almost an hour or so. So yeah, I'll be briefly introducing madam some of the important awards and achievements. Madam is the postgraduate examiner, a peer reviewer for various journals of repute, including IJA, associate editor IJA, assistant editor Journal of Anesthesiology, Clinical Pharmacology, awarded ISA, IJA Test Peer Review Award 6970 by IJA, ISA Proficiency Award 2021. Under her leadership at ISA Hubli, she also the city branch has got been awarded the best city branch and also for Easter Day celebration in the year 2017 and 18. She has authored 70 plus journals, with publications, 2 national guidelines on the book she has authored and 3 books chapters she has contributed. Her areas of interest are medical education, anesthetic pharmacology, research and publications, obstetric anesthesia, supraglottic airway devices, and many more. With this brief introduction, I hand over my mic to Madam Madhuri Kulkarni. Thank you.
Am I audible?
Yes, ma'am.
Am I audible? Thank you very much, sir. Thank you very much, sir, for that nice introduction. And I'm really happy to be sharing this podium today on for this CME at Vijayapura. And it would have been very nice if I could have physically attended the CME and met you all. Anyway, today I'm here online. So at the outset, I would thank Patil madam and your entire organizing committee for having given me this chance to present this talk on critical care in obstetrics at this CME, which is dedicated to the theme of obstetrics. So I'll just share my screen now. Yes. Are the slides visible?
Yes, ma'am.
So, over to the topic, critical care in obstetrics. I bring you warm greetings from my institute, Karnataka Institute of Medical Sciences, Hubli. So the topic today is critical care in obstetrics. I think Sarojini madam just touched upon labor analgesia some time back, and we have some more topics related to obstetrics. So whatever happens, whether it is labor analgesia or whether it is anesthetizing an obstetric patient in the operation room, our role as an intensivist in the critical care unit is very, very important. And the concept of obstetric critical care unit is advancing day by day. And I'm very proud to say that in our institute at KIMS Hubli, this concept of an obstetric critical care unit came into existence some years back. And when we tried to establish the obstetric critical care unit, there was not much of support from the administration. Everybody was asking, what is the need to have such a critical care unit? Why can't you keep them in your general critical care unit? And so on. So we went at a slow pace, but today we have a separate building dedicated only to maternal and child health, and there we have a dedicated obstetric critical care unit. And in that critical care unit, we have got a dedicated physician and a dedicated intensivist, and we have postgraduates posted round the clock in these obstetric critical care unit. So with this short background, let us see let us see some important points about obstetric critical care. So the pregnant women requiring obstetric critical care admissions is quite low in the developed nations, and it ranges from around 0.9 to 1% roughly. And in India, it is much more. It is about 3 to 8%. Of course, this is not very recent statistics, but this is what I was able to get. Now, there are some potentially life-threatening conditions during pregnancy, labor, and after termination of pregnancy. And some of these patients, they die. And when they die, this is known as a maternal death. And a proportion of them narrowly escape death. And these cases are known as near misses. And maternal near miss and maternal death together, they form the severe maternal outcome. So whenever a maternal death occurs or a near miss occurs, it's a very, very serious issue. And it is investigated, the causes of the death, like exactly what happened, what were the reasons leading to the maternal death. All this is probed by the obstetrics and anesthesia department and the administration whenever such a maternal death or a near miss occurs. So it is taken very seriously. Now, the World Health Organization defines maternal near miss as a woman who nearly died but survived a complication that occurred during pregnancy, childbirth, or within 42 days of the termination of pregnancy. Severe maternal illness is another life-threatening condition for a pregnant woman, and it often requires admission into the ICU. So when we talk of obstetric critical care, we should know all these terminologies. What is a maternal near miss? What is maternal death? And what is a severe maternal illness? All these terms we should be able to understand. Now, what are the causes? There are various causes of critical illness in pregnancy. There are some conditions where the pre-existing disease will be there in the mother and that will worsen during pregnancy. Then there are some cases of increased susceptibility during pregnancy, and there are some other obstetric causes of critical illness in pregnancy. Now, I will not go into all the causes, but I'll just name the critical obstetric causes of critical illness in pregnancy. Most important is the hypertension, hypertensive disorders of pregnancy. We have all seen these cases of PIH getting admitted into the obstetric critical care unit because of development of some complication. So hypertensive crisis, severe preeclampsia, magnesium toxicity, HELP syndrome, eclampsia, all these are complications of PIH. Then the others include PPH due to abruption, rupture of the uterus, uterine inversion, retained products of conception, adherent placenta or placenta percreta, acute fatty liver of the pregnancy, and of course obstetric hemorrhage and ruptured ectopic. All these are can lead the patient to get admitted in a critical care unit. Then we have sepsis, which is one more major condition which is seen in the obstetric critical care unit. Sepsis due to chorioamnitis, septic abortions, endometritis, ovarian hyperstimulation syndrome, amniotic fluid embolism, and peripartum cardiomyopathy, chocolytic induced pulmonary edema, and heart failure. All these are the obstetric causes of critical illness in pregnancy. Then there are some non-obstetric causes like the acute respiratory distress syndrome, acute kidney injury, urosepsis, diabetic ketoacidosis, acute pancreatitis, drug abuse, and then many more. So what are the type of cases that you get in an obstetric critical care unit? This includes primary obstetric disorders and non-obstetric disorders. Primary obstetric disorders, as I told you, most of the cases, 80% cases are preeclamptic cases, preeclampsia and its complications, hemorrhage, and sepsis. Non-obstetric disorders, again, there is geographical variations. In the Southeast Asian countries, we have infectious diseases, rheumatic valvular heart disease, cerebral sinus thrombosis, and endocrine disorders. In the developed nations, the picture is slightly different. You have cases with pneumonia, bronchial asthma, trauma, cancers, drug abuse, urinary infections, autoimmune disorders, chronic pulmonary disease, pulmonary thromboembolism, corrected complex congenital heart disease, and organ transplant. You know, you often get patients of renal transplant nowadays coming for cesarean section. Okay, so many of them can land into the ICU. Now, the first question that would come into your mind is, okay, how is obstetric critical care different from non-obstetric routine critical care? So, in general, what is the need for this lecture? Okay, why am I talking about obstetric critical care specifically? Is it any different from non-obstetric routine critical care? Well, it is. It very much it is. And why? It is due to three important reasons. So the first reason is the altered physiology of pregnancy. So we know that the pregnancy is associated with physiological changes in almost every organ system. And this is very important when you're dealing with critical care. Then comes the anatomical changes which take place in the mother. They pose a challenge in the management of the patient in the ICU. And then, of course, the fetus. There are two lives, you know, that we have to care for here. So the concerns for the viability of the fetus, that the fetus should also remain alive when you're doing any maneuver in the obstetric ICU, this is one more cause for concern. And then, of course, all this is exaggerated. These changes are exaggerated when there is a superimposed pathology like eclampsia or pulmonary edema. So what is required in obstetric critical care? Early recognition of the signs of acute deterioration. This is very, very, very important. You should be able to recognize the signs of deterioration early. After that, you have to do a quick referral to a center which can deal with all these type of cases, transportation to a higher level of care with early institution of therapy. So what are the causes of delays in the early intervention and receival of care? So if there's early intervention and receival of care, there are less chances of the patient developing severe critical illness. But what happens, unfortunately, this does not happen because the patient fails to seek care. And what is the reason for that? In our country, the most common reason is financial constraints. The patients are very poor. They're not able to afford even transportation to come to the higher center. cultural beliefs. They have so many beliefs that it's okay, this can be treated at home or whatever. Then poor education, poor literacy level, low awareness of available services. Sometimes transport itself will not be available for women living in remote villages of India. Delay in reaching the care because of scarcity of hospitals and if the hospital is far off. So first we will just discuss the general management of an acutely ill obstetric patient and then go on to some specific conditions. Now the initial assessment is the same as for a non-pregnant female, nothing different. The ABC, the airway, breathing, circulation is assessed and stabilized, and the patient is transferred to an appropriate level of care, as I told you. Now what are the levels of care? Level 1 is it's routine care. You can give it to the patient in the labor room or in the ward, wherever. Whereas for critically ill obstetric patients, we have got levels 2, 3, and 4. Level 2 care can be provided in a high dependency unit, or you have what is called as a mobile maternity unit or a labor room. In the side room of the labor room, you can provide this level 2 care. Level 3 and 4, of course, have to be provided in a critical care unit only. So recognition, I said that first of all, you have to recognize that the pregnant woman is deteriorating and this is life-threatening but potentially reversible. And if it is so, then you have to transfer the patient to an appropriate level of care, level 2, 3, 4, like that. And then the response, the provision of a multidisciplinary care plan with obstetric interventions or specialty interventions. For example, radiological interventions in a case of PPH, all this becomes very important. Now, the critically ill pregnant patient, she will have all sorts of organ failure or organ dysfunction. So, when you give organ support to such a patient, what should you remember? Please keep one thing in mind, that whatever is good for the mother is good for the fetus. This is the principle. Whatever is good for the mother is good for the fetus, and of course, whatever is bad for the mother is bad for the fetus also. So this is the basic principle which you should keep in mind. Now, a little about organ dysfunction trends in an obstetric patient, how it is different from non-obstetric patients. So this is the data from Fernandez Hospital and in Hyderabad, and it shows the trends in organ dysfunction. So you see the maximum dysfunction occurs in the lungs, 89%, followed by the MODS, multi-organ dysfunction syndrome, 73%, followed by DIC, 47%. Then comes cardiovascular system dysfunction, 36%. Then renal problems, 26%. And then GIT and other CNS and other systems. So this is a trend of organ dysfunction that I could find in an obstetric critical care unit, but the trend may vary from place to place. Now let us see system by system, starting with the airway management and support. See, this airway management occupies the highest priority because these pregnant women, they desaturate fast. Why do they desaturate? Because of the physiological changes which have already taken place in the respiratory system. So you have to follow the DAS, the Difficult Airway Society UK, and the IDA guidelines are there, and you have to follow these when you do the airway management. And for doing this, the obstetric ICU has to be well equipped with the difficult airway equipment like second generation supraglottic airway devices, video laryngoscope, cricothyrotomy sets, and so on. Then comes the breathing and ventilation. To maintain the gas exchange, use supplemental oxygen and high concentration oxygen mask. And you can also use transnasal high flow humidified oxygen and non-invasive ventilation, but that has not been adequately studied. But especially this was made use of during the COVID pandemic. So the target should be to maintain a PaO2 of more than 65 to 70 millimeters of mercury, a PaCO2 of less than 45 millimeters of mercury, PaO2 minus FiO2 by PF ratio of more than 150, and a plateau pressure of less than 28 centimeters of water. Endotracheal intubation and lung protective mechanical ventilation strategies should be started if these ventilation targets are not achieved. Use PEEP judiciously. Permissive hypercapnia, which is one of the strategies, ventilatory strategies, protective ventilation strategies, it is poorly tolerated in pregnant patients because a PaCO2 gradient of 10 millimeters of mercury at least is needed for feto-maternal transfer. Otherwise, fetal respiratory acidosis is going to set in. Now, if there is refractory hypoxemia in spite of doing all this, in spite of adopting all these ventilatory strategies, you can give semi-prone ventilation, complete prone ventilation, and termination of pregnancy if the gestational age is more than 22 weeks. Then there is one more strategy, that is extracorporeal membrane oxygenation therapy, that is ECMO. Circulation, you should maintain an adequate uteroplacental perfusion, and patient may be in shock. If the patient is in shock, there are various causes of shock in a pregnant patient: hemorrhagic, septic, cardiogenic, and so on. You need 2 wide bore IV lines, arterial line, central line. Central line, remember, don't take any central line below the diaphragm. Avoid femoral line. Subclavian route is also avoided. Best is to take an internal jugular vein, central line, because access is the best and best for this internal jugular vein. And if the gestational age is more than 20 weeks, don't forget to give the left uterine displacement. Either you can give manually, you can manually displace the uterus, or you can give a wedge of 25 to 30 degrees below the right buttock. Then gastrointestinal system support. Please remember that pregnancy, labor, and lactation, they are high calorific state conditions. So you have to give them good nutrition, good caloric support. And if they are starved, these women tend to develop early ketosis. And the enteral route is well tolerated, and you can use it in the ICU. That will become the primary choice of feeding. ECMO, successful outcomes have been reported with the use of venous ECMO and veno-arterial ECMO have been reported in pregnancy, both antepartum and postpartum. Then, of course, other organ support like for the renal system and so on, that is as for a non-pregnant patient. Now comes the monitoring. Once you have a critical ill patient in the obstetric critical care unit, what monitoring are you going to do? CVP is mandatory. As I already told you, better to take the internal jugular vein. Invasive arterial pressure may be used depending upon the condition. For example, a patient of PIH in severe pulmonary edema, then you may have to put an invasive line, arterial line. The inferior vena cava ultrasound. This is a new modality which has come up, where with the help of ultrasound, you measure the diameter of the inferior vena cava, and by measuring this, you can find out the collapsibility of the inferior vena cava, and the collapsibility of the vena cava tells you about the volume status of the patient. So this is one new modality which is coming up, and several articles are being published on IVC ultrasound. Then comes the transesophageal echocardiography. This can also be used for volume assessment. And continuous cardiac output monitoring, it is not useful antenatally because of the aortocaval compression, but you can use it in postpartum patients. Then, of course, the fetus, you cannot forget the fetus. Fetal well-being, you will have to monitor. The biophysical profile, which includes the fetal breathing, tone, movement, amniotic fluid volume, non-stress test, all these can be done. Then comes the arterial blood gas interpretation. It is slightly different from a non-pregnant woman in that the normal pH itself in this pregnant woman will be around 7.44. It will be little alkalotic. PaCO2 will be around 28 to 32 millimeters of mercury. Base deficit up to -5 is acceptable. Bicarb 20 to 22 millimoles per liter. PaCO2 more than 35 indicates imminent respiratory failure. More than 40 indicates respiratory failure. PaO2 95 to 105 millimeters of mercury is normal because pregnancy is considered to be a hypoxic state. Now comes this one new modality of monitoring in the obstetric critical care unit, that is ultrasonography. Ultrasonography nowadays has now, it has come up, not only is it being used in the as an adjunct for regional anesthesia for giving nerve blocks in the orthopedic OTs or in the surgical OTs, but now it is being used even in critical care, and not just in critical care, but in obstetric critical care. So it is a very safe, easily accessible and inexpensive imaging modality. And POCUS is an upcoming thing. POCUS is nothing but diagnostic or procedural ultrasound guidance, which is performed at the bedside by the clinician for obtaining rapid evaluation and assessment or even treatment of the patient. So you can do POCUS in an obstetric critical care patient. The obstetric intensivist himself or herself can do this POCUS. So what are applications of POCUS in obstetric critical care? There are various applications. You can use POCUS to locate the cricothyroid membrane in case you have an obese lady. If you think that this patient is having a difficult airway and you are going to have a tough time intubating her in an emergency situation, what you can do, you can locate the cricothyroid membrane with POCUS so that in case you have to go for cricothyrotomy, you will not have to have any problems. Then, of course, for gaining vascular access, central venous access. Then the drainage of pericardial and pleural effusions. Then assessment of deep vein thrombosis. And ICP measurement, intracranial pressure measurement in severe PIH cases. You can do ocular ultrasound. I will come to that shortly, what it is. Then lung and thoracic ultrasound, that also I'll be explaining. Then transesophageal echocardiography, I already told you about it. This TEE, you can use it for the early detection of lung congestion and pulmonary edema. Focused cardiac ultrasonography can be done. And you can use ultrasonography nowadays. It is also being used for assessing the diaphragmatic tone during weaning from mechanical ventilation. So for weaning to be successful and as a guide for successful weaning, you can use the ultrasound in the critical care unit. So this is one of the recent editorials in the IJA, which focused or which stressed upon advancing how obstetric critical care is now changing. It is being reshaped or it is being strengthened and advanced by the application of POCUS or point of care ultrasound. This is one more review article from the Journal of Anesthesia and Critical Care, which says that ultrasound can be used as a diagnostic and monitoring tool especially in emergency and critical care scenarios. And it can be an asset for emergency and critical care management in obstetrics. So as I told you, the ultrasound for identification of the cricothyroid membrane, it can be used in obese obstetric patients. Then comes lung ultrasound in obstetric critical care. So what is it being used for? What will you do with the help of POCUS? So you can use it to quantify the extravascular lung water in cases of pulmonary interstitial syndrome. You can use it in severe preeclampsia to detect subclinical pulmonary edema. Then if there is a case of pulmonary edema, it will help to identify early cases of severe preeclampsia in whom excess fluid is to be avoided to avoid pulmonary edema, and to identify and grade presence of extravascular lung water before it clinically manifests. So in short, to tell you, in cases of pulmonary, in cases of PIH, pulmonary edema is very, very common in cases. It's a common complication of PIH. And once the patient develops pulmonary edema, it is very difficult to treat. So even before it clinically manifests, you can make out the presence of extravascular water in the lungs with the help of lung ultrasound. Various parameters are there to detect. And once you know that this patient has extravascular lung water, you can, adjust your clinical management accordingly. You can adjust your fluid management accordingly so that the patient will not develop overt pulmonary edema. So I'll just tell you in short the technique, the scanning technique. There are various techniques which can be used. So I'll just tell you the 8-zone technique which can be employed in the emergency setting. It consists of scanning 4 chest areas per side. Areas 1 and 2 denote the upper and anterior and lower anterior chest, whereas areas 3 and 4 denote the upper lateral and basal lateral chest. And if the patient is critically ill with acute respiratory failure, There is one more fast technique, rapid anterior two region scan can be used, and this can rule out the interstitial syndrome due to cardiogenic acute pulmonary edema. So I just took these pictures, this is from our own institute. You can see over here, see, look at this over here. This is nothing but the, that was nothing but the, this is known as the Comet B line, Comet B line. And this I took from Google. This is from our own institute where we did a study actually on lung ultrasound. We are doing a study, and these are the the A lines you can see over here. So what are these B lines, A lines? Well, the A lines are nothing but horizontal echogenic parallel lines below the pleura. You can see them over here. So how do they occur? They are a result of a reverberation artifact between the ultrasound beam and the pleural lines, and they indicate normal lung aeration when lung sliding is present. And B lines, they are longer, hyperechoic, discrete, vertical laser-like lines of the interlobular septa, which occur due to fluid accumulation in the interstitium and alveolus, and they extend to the bottom of the screen without fading, and they move synchronously with the lung. See, look at these. They extend to the bottom of the screen without fading. Okay, and what do? They move synchronously with the lung. So you can identify these A lines, B lines. Then there is something called as a B line pattern, and this signifies, it is a sign of pulmonary edema. Then what is a B pattern? Then we have something called, in pulmonary interstitial edema, what happens is you get 3 or more B lines in 2 or more bilateral lung fields. And the number of B lines across the imaging field will correlate with the severity of interstitial edema. Okay. So if there are multiple B lines which are 3 millimeter or less apart, then they are caused by ground glass areas and they represent alveolar edema. Pulmonary interstitial syndrome, here you get a bilateral B line pattern on lung ultrasound and associated with the diastolic dysfunction. And pulmonary interstitial syndrome is actually a sonographic entity, and it can be caused by pulmonary edema. Then I told you about the comet tail, and also what is echo comet score, what is E wave, E dash wave, E dash ratio. So it is not just diagnosing the presence of extravascular lung water or finding out these scores, but you have to find out the reason behind the presence of extravascular lung water in the lung of a pregnant critically ill patient. So for that, you have to find out all this. By cardiac ultrasound, you find out parameters like the E dash wave, the E dash ratio, which is a marker of diastolic function. So when this ratio is altered, you know that there is diastolic dysfunction, and probably that is the cause of the pulmonary edema. B-line score, lung ultrasound score, so many such scores. See this study. This is a study by Ambrosic et al. Lung and cardiac ultrasound for hemodynamic monitoring of patients with severe preeclampsia. Then lung ultrasound predicts interstitial syndrome and hemodynamic profile in parturients with severe preeclampsia. And this study concluded that lung ultrasound detects both pulmonary edema and increased left ventricular end diastolic pressure. And once you find a B pattern on lung ultrasound, you have to restrict the use of fluid in this particular patient. Thoracic fluid content, it is again a novel parameter for the detection of pulmonary edema in parturients. And you can do this by calculating the lung ultrasound. Then this is one more novel thing, detecting the intracranial pressure. You know, the intracranial pressures will rise in a case of PIH or preeclampsia, eclampsia. So what you do ocular ultrasound, and with the help of ocular ultrasound, what you do is you try to find out the diameter of the optic nerve sheath. And they say that when the intracranial pressure increases, the optic nerve sheath diameter also increases. So there are several cutoff points for the optic nerve sheath diameter, and when this cutoff point is when you cross this cutoff point, that means the patient has got increased intracranial pressure. So this is a very nice non-invasive way of detecting intracranial pressure rise in the eclamptic parturient. Look at this. The optic nerve ultrasound for fluid assessment in patients with severe preeclampsia. So many studies are going on this optic nerve sheath diameter, and they have found that the optic nerve sheath diameter is higher in patients with eclampsia, suggesting raised intracranial pressure. And when the pressure decreases with subsidence of the disease process, the optic nerve sheath diameter also reduces, and it is suggested that this can be used as a routine monitoring in these kind of patients to guide management and predict the prognosis. But further studies are going on this. So the technique of ocular ultrasound, the Dubost technique is used, and in which the optic nerve sheath diameter is measured around 3 millimeter behind the globe with a linear probe. So it is performed with the patient in the supine position with the closed eyes, and a layer of ultrasound gel is applied over the closed upper eyelid, and the linear high frequency probe 7 to 12 megahertz ultrasound is placed on the temporal area of the eyelid, with the hand holding it resting on the forehead of the patient. And the ONSD is then measured 3 millimeter behind the globe in the transverse plane perpendicular to the optic nerve. Then TEE, transesophageal echocardiography in obstetric critical care. With this, you can assess the myocardial contractility, the preload, the end diastolic volumes of the ventricles. You can find out the cause of hypertension, tachycardia, sepsis. It can be used in the diagnosis of pulmonary embolism and hemorrhage, in the diagnosis of shock, and for the assessment of intravascular volume and fluid responsiveness. So look at this, the TEE and the passive leg raising test can be used to identify women with preeclampsia who can respond to fluid therapy by an increase in the cardiac output. So it is said that 14% of women with severe preeclampsia are fluid responsive. And besides this, USG can be used to identify pleural effusion, consolidation, etc. in the ICU. And an ultrasound probe is very, very easily available, in the obstetric suite, and therefore doing POCUS is not at all difficult. So this is a systematic review on point of care ultrasound. I am one of the authors for this, and we had done a systematic review on this topic, and we found that focus parameters, like as I told you, the lung ultrasound score, the echo-comet score, the optic nerve sheath diameter, all these can be useful as early markers of fluid status and serve as useful tools in the management of preeclampsia, especially severe preeclampsia. So they say that POCUS is a very powerful tool of the anesthesiologist, and it has literally revolutionized and strengthened obstetric critical care. So it is like the new lamp in the labor room and obstetric critical care unit, and we should all be making use of it, of this astra. Now, the decision after having managed the patient, we have to remember that the fetus is still inside the mother. So when to deliver the baby and how to deliver it is one more question which is foremost in our minds. So once you stabilize the mother, now think of the fetus. How you evaluate the fetus? If you do delivery in time, it will improve both maternal and fetal outcomes. Try to have a multidisciplinary team approach. The risk of preterm delivery exists. Explain this to the relatives. Delivery set should be ready in the obstetric critical care unit. Give steroids for fetal lung maturity if the fetal age is more than 20 to 24 weeks. Avoid beta-2 agonist as tocolytics. And if fetal delivery is imminent, you can give a loading dose of magnesium sulfate followed by an infusion. Other principles to be followed, avoid maternal hypertension, hypoxia, anemia to prevent fetal death. Try to maintain maternal hemoglobin more than 5 grams per deciliter. Correct coagulopathy before surgery or vaginal delivery. Then, you do the Krehor-Betke analysis to detect fetal red cells in the maternal circulation in an Rh negative pregnant woman, if it is a case of trauma or massive abruption or amniotic fluid embolism. And if it is positive, you have to give anti-D immunoglobulin. Breastfeeding in the ICU, you encourage breastfeeds early, even if the mother is on ventilator support. Early maternal bonding is very, very useful to help you wean the mother from mechanical ventilation. Please remember this. And the mother will be on multiple drugs. And but please remember that very few drugs contraindicate breastfeeding in the mother. Then, in the ICU, we will have so many imaging modalities like chest X-ray, X-ray spine, X-ray abdomen. So they will give different doses of radiations. And will it harm the fetus? Well, X-ray abdomen, lumbar spine, IVP, CT chest, they do expose the baby to radiation, but it is low to moderate. And if it is CT abdomen or pelvis, high dose radiation. So you have to keep this point in mind when you subject the mother to these kind of procedures. A few words about cardiac arrest in pregnancy. There are various causes starting from anaphylaxis, anesthetic causes. Maybe in the OT, the mother can go into arrest. Bleeding, bleeds everywhere in the brain, in the liver. Cardiac causes, drugs like magnesium toxicity, eclampsia, embolism of all kinds, uterine abruptio, rupture, inversion, and pulmonary causes like ARDS, pulmonary edema, adherent placenta, retained placenta, and sepsis. So when you do CPR in pregnancy, what is special of CPR in pregnancy from a non-pregnant patient? The mother during CPR is kept in the supine position with left uterine displacement. It is very important during chest compressions. Please remember that the mother is prone to develop early hypoxemia because of the physiological changes of pregnancy. You know that the fetal demands are there here and the FRC is reduced and there are so many other changes. So you have to, you have to give oxygen early, and it is better if you intubate the patient early because there are high chances of aspiration. Acquire venous access preferably in the upper limb or the neck, as I told you. Give standard 200 joules shock if rhythm is shockable. And if return of spontaneous circulation within 4 minutes is not possible, then you can please go in for perimortem cesarean section, which is done at the site of cardiac arrest. And if ROSC is not established by these methods, then if facilities are available, you can go for veno-arterial ECMO. So CPR in pregnancy, the same ratio, 30:2. Then you can go for defibrillation and chest compressions. They are very safe. There is no harm of the defibrillation to the fetus. Early tracheal intubation, as I told you, and intubation may be difficult because of the anatomical changes of pregnancy, which I'm not going to tell you. I'm sure you know about them. And when you intubate, there are high chances that bleeding can occur, and you have to keep small size tubes ready. High quality CPR plus 30 degrees left lateral tilt or manual displacement of the uterus is very important. Perform cesarean section, I already told you, after 4 minutes of unsuccessful resuscitation. And please remember that when you're doing active CPR, please do not waste time doing fetal assessment. Don't assess the fetus during active CPR. Concentrate on the mother. Please concentrate on the mother. Defibrillation, minimum energy pass to fetus, so it is very safe. Only thing, when you place the paddles, please remember you use anterolateral defibrillator pad placement. Keep the lateral paddle underneath the breast tissue. A few words about perimortem cesarean delivery. I thought you would be interested in this. So I told you have to do it within 4 minutes of cardiac arrest. It facilitates resuscitation by relieving aortocaval compression, and early delivery of the baby will decrease the neuronal damage in the baby. But the decision to do this perimortem delivery depends on whether the gravid uterus interferes with maternal hemodynamics. So it all depends upon the gestational age and how much the gravid uterus is interfering with maternal hemodynamics. So especially in a patient with excess of amniotic fluid or in a twin pregnancy, the amount of interference of the gravid uterus with the maternal hemodynamics will be very high. And within 5 minutes, the delivery should take place at the 5th minute of arrest. And you perform it at the site of arrest. No need of shifting the patient to OT and all. Don't waste time for that. And don't waste time for preparing the abdomen or waiting for surgical equipment. Only scalpel is enough to start. Just pour antiseptic solution on the mother's abdomen. Continue resuscitation during this procedure. Maintain left uterine displacement. And the position of the rescuer who is performing the manual left uterine displacement will have to be adjusted. Either vertical or Flannan steel incision can be used depending upon the surgeon. Whichever incision he is favorable with is favorable to him. And then you close the uterine incision and abdomen in the regular fashion. And now you can place the Foley's catheter, because initially you didn't have time to place the Foley's catheter. And then you can, if the uterus is flabby, post-delivery prophylactic clamps and sutures can be placed on the uterus. And please remember that oxytocin in ectonic uterus, if you give at this stage, it can precipitate cardiac arrest. Judicious use of uterotonics is another important point. And there are several cases reported where the mother has survived with perimortem cesarean delivery performed up to 15 minutes after the onset of maternal cardiac arrest. See, this is a very interesting case series which I found, a case series of perimortem cesarean delivery during maternal cardiac arrest. So the authors have, this is a study from Punjab, and they have said that they have reported 5 cases. And in this, 2 mothers had a return of spontaneous circulation, whereas return of spontaneous circulation could not be achieved in 3. And poor survival rates in their place, they have said, reflect the need for reinforcement of early perimortem cesarean delivery, use of cognitive aids, and training the obstetric critical care unit people with mock drills and simulation of perimortem cesarean delivery for better outcomes in the future. So a few words about some scores and indices which are used in obstetric critical care. This is the WHO near-miss criteria for cardiovascular and respiratory system dysfunction. So in the cardiovascular system, marker for organ dysfunction is shock, cardiac arrest, use of continuous vasoactive drugs, cardiopulmonary resuscitation, and severe hypoperfusion with lactate levels less than 5 millimoles per liter. Respiratory dysfunction is acute cyanosis, gasping, dyspnea, bradypnea. Renal dysfunction, coagulation, hepatic dysfunction, neurological dysfunction, uterine dysfunction. For all these dysfunctions, you have several markers. So the WHO near-miss criteria identifies maternal near misses and predicts mortality with 100% sensitivity and 79.66% specificity. So like that, there are various risk prediction models for maternal mortality. For example, the C4 model, which is a collaborative integrated pregnancy high dependency estimate of risk. It is being used in the obstetric population. The maternal severity index, again, it applies to hospitalized obstetric patients, and it is very useful to predict risk in the obstetric critically ill patient. And by predicting the risk, you can adopt proper management strategies. You can use hospital resources in a better way, and by this way, you can reduce the maternal mortality. Maternal severity score at admission to the PACU, it can be used again to reliably predict mortality, and it can be used as a preoperative risk assessment tool as well. This obstetrically modified quick SOFA score is a very, very nice score. There are 4 parameters in this: the systolic blood pressure, the respiratory rate, and the altered mentation. So each of these 3 parameters is given a score of 1, and this particular score is very, very useful in obstetric patient. The SOFA score has been widely used in the Western world, but in developing countries, there are limited studies for the use of the SOFA score in predicting outcome of severely ill obstetric patients admitted in an ICU. There's one more index, the shock index, which is defined as the ratio between heart rate and systolic blood pressure, and it has been proposed as a useful and reliable tool to predict hypovolemic states and early hemodynamic compromise, especially in major obstetric hemorrhage, even when the individual has normal vital signs. Then the mini PIRES, this is a preeclampsia integrated estimate of risk. This prediction model provides a simple tool to identify pregnant women at an increased risk of death or major complications of preeclampsia. And this model includes parity, gestational age on admission, headache, chest pain or dyspnea, vaginal bleeding with abdominal pain, systolic blood pressure, and dipstick proteinuria. There is one more full PIRES model which can be again used in women with preeclampsia at high risk of adverse maternal outcomes in need of immediate interventions. This model requires laboratory testing of platelet count, serum creatinine, lactate dehydrogenase, aspartate transaminase, and alanine aminotransferase levels. Now, there are some ethical dilemmas in critical care. Okay, what is the ideal time for delivery of the critically ill mother? Suppose the mother is critically ill but unstable, and the term pregnancy with fetal distress, then should one terminate the pregnancy? Sometimes there is co-ICU admission, that is a sick mother delivers an even sicker baby and both of them require intense organ support. Then there can be a brain dead parturient with fetus near viability age. In such a case, should support be prolonged to maximize the fetal viability? So there are several such dilemmas and discussion is going on these various aspects. So if you want to have a successful maternal and neonatal outcomes in a critically ill obstetric patient, this needs multidisciplinary input from intensivists, obstetrics, anesthesiologists, obstetricians, fetal medicine specialists, neonatologists, and other specialties. So to improve obstetric critical care, you need to use POCUS, training physicians and intensive. Just having POCUS is of no use. You need to train people in the use of POCUS, use of early warning scoring systems, use the WHO near-miss approach, maternal severity score, shock index, and multidisciplinary interventions. Then there are some specific conditions, for example, in sepsis, you can use these MOEWS, that is it's a modified obstetric early warning scoring system. Then SOS, that is sepsis in obstetric score. All these can be used in a parturient with sepsis. And take care of coagulopathy, multi-organ failure occurring in sepsis. And sepsis, the source will mostly be chorioamnitis, pyelonephritis, endometritis, or pneumonia. So we have what is called as the golden hour in sepsis. You have to move fast during this period, implement the sepsis bundles fast. Laboratory radiological studies for the etiology and the source control are very, very important. Choose proper antimicrobials. Start fluid resuscitation if the blood lactate is more than 4. Give 30 ml per kg crystalloid initially. Passive leg raising test can be used in the case of sepsis. And beyond the golden hour, your escalation of care is very, very important for survival. And please anticipate that adverse pregnancy outcomes can occur. So various lab studies are there for the evaluation of maternal sepsis, including serum lactate, coagulation studies, arterial blood gases, pulse oximetry, serial lactate, and the ventilatory strategy in these patients of ARDS has to be low tidal volume ventilation, lung protective ventilation strategies. Patients of amniotic fluid embolism are sometimes, rarely they can get admitted to the ICU. They will have DIC, severe hypoxic respiratory failure, seizures, diastolic dysfunction, acute lung injury, multiple organ failure, cardiac arrest. So please give them all system support depending upon which organ or system is failed. Pregnancy-induced hypertension, we are all well versed with the management of this. Patient can have seizures, status eclampticus, intracranial vasospasm, intracranial hypertension, hepatic failure, HELP syndrome, which may be sometimes superadded with an acute fatty liver. So all these conditions have to be treated. In PPH, PPH can occur, and there are various types of obstetric hemorrhage, including antepartum, intrapartum, and postpartum hemorrhage. As I told you, antepartum hemorrhage, most common cause is placenta previa, abruptio placentae. Postpartum hemorrhage can be primary or secondary. Primary is within 24 hours of birth, and secondary is after 24 hours. And third stage PPH can also occur after expulsion of the placenta. There are various causes of PPH. Tranexamic acid, please remember, can be used as a prophylactic and therapeutic measure in PPH. And sometimes you may have to give massive blood transfusion and use the massive transfusion protocol in cases of PPH. So you can, what is massive transfusion? Replacing one entire blood volume in 24 hours, or transfusion of 5 units of packed cells in 3 hours. So the massive transfusion protocol you can use, it's a standardized protocol to help the clinician to ensure effective management of blood loss and improve outcomes. It's a ratio-based proactive transfusion in the initial stages of resuscitation. And this protocol has a predefined ratio of FFP or cryo precipitate, platelet units, and RBCs in each pack in a ratio of 1:1:1. It is activated by the clinician in response to massive bleeding in a pregnant woman with estimated blood loss more than equal to 2 liters and ongoing bleeding. Either the ICU physician or anesthesiologist can activate it based on clinical judgment. So there are various massive transfusion protocols in obstetrics. Several targets are to be monitored during the protocol. You can use thromboelastography and rotational thromboelastometry for real-time coagulation evaluation in a bleeding parturient. And you can stop the protocol. You can take the decision depending upon the control of bleeding and the hemodynamic improvement. So this massive transfusion protocol is something which is not being used in all hospitals in India, but which can be used, and it helps the best component of best management of blood component loss during massive blood loss, and it interrupts the lethal triad of acidosis, hypothermia, and coagulopathy. But it has got several limitations, like they say it leads to wastage of blood products, and it is not standardized, and there can be hyperkalemia, dilutional coagulopathy, platelets may not be available, and blood resources may not be available all institutions. And massive transfusion protocol in obstetrics, a lot of systematic reviews on this, and I found this very interesting study, utility of viscoelastography with TG6S to direct management of hemostasis during obstetric hemorrhage. So here, this particular device has been used. You can use it at the bedside to identify low fibrinogen, which is a very common cause of obstetric hemorrhage. So to conclude, please remember that in obstetric critical care, what is good for the mother stabilizes the fetus. Primarily, all resuscitation efforts should be focused towards maternal stabilization. Delay in delivery leads to loss of mother and fetus or both. Experience, wisdom, evidence, multidisciplinary teamwork is useful in obstetric critical care, and no effort should be spared in the management of the critically ill obstetric patient because their outcomes are often dramatically better than exposed. Thank you. Thank you very much.
Thank you, madam, for the excellent lecture, focusing more on the focus on the ultrasound. Most of the centers still lacking this particular instrument. Even most of the medical institutions is still not having the high dependency units or special care for obstetrics. And most of the obstetrics emergencies occur in the ASA grade 192 itself. And most of the anesthesiologists, institution or in private, might have come across near misses so many times. And somehow we have been lucky enough to resuscitate pregnant women, and sometimes we have also come across postpartum hemorrhage where we are lacking the basic fluid resuscitation, especially in terms of blood, replacement of blood. And this has been to refer to other cities because of lack of
centers
care in obstetrics. I think most of the agree to this, and the concept of obstetric ICU has come off late, and especially during these 2 years of pandemic, that has also initiated the obstetric in general the critical care beds. So thanks for our government for providing so many infrastructure, especially in terms of ventilators and other infrastructure. Thank you, madam. The topic is open for discussion. If any queries are there, then please ask madam. Anybody from the audience? There is one question.
What is it?
Hello. Good afternoon, ma'am.
Good afternoon.
Ma'am, my question is like in a country like India, where we have very minimum facilities available.
Yes.
If a patient always will come to the hospital in an end stage, like in a very severe condition. So, what is the utmost priority that we have to give? What is the utmost thing first we have to do to this patient? But even in hospitals also, like we don't have the equipment or anything, all that we need to monitor. Like, what is the utmost priority that we have to do?
utmost priority, see, at right now, like I was speaking about focus and all those things. So that now these machines or devices may not be available in the periphery, as you rightly said, you rightly pointed out. So in such situations, I would say that you have to go on to the various scoring systems. You know, I was talking about so many scoring systems, especially the meows, the sauce, and the maternal shock index. All these, these are very easy to implement. You don't need any devices to implement these scoring systems, and they can warn you that this patient is going to need a higher level of critical care, and according to that, you can, plan your strategies. So that would be one new thing which I want to tell you through my talk. The other things, whereas see, getting an ultrasound machine is not very difficult. I told you that ultrasound is always available in the labor room, right? It's always available. So you can do focus. It's not that you cannot do focus, only you have to get trained in doing focus. And by doing focus, you can find out so many things. I was talking about lung ultrasound, all those things, but you need to get trained in that, definitely. So there is a learning curve for that. And as regards the other strategies, the airway, breathing, circulation, you have to continue with whatever we are routinely doing. But especially in PPH now, we have got newer things coming up like thromboelastography, ROTEM, and I told you about, bedside only you can assess the coagulation, because you should understand what exactly is the coagulation abnormality which is occurring in the mother leading to PPH. And if it is sepsis, early implementation of the sepsis care bundles. So, and doing CPR in the right way, and perimortem cesarean delivery. These are some new things which something different which we have to implement in the pregnant mother.
Thank you.
Anybody else, you can just put it in the chat box.
20% is the chat box.
11 questions.
Meanwhile, madam, the other day, last month or 2 months back, we had a critical care incident in either obstetric or non-obstetric case, wherein the treatment was given against the doctor for not having obstetric care or not having ventilator. I don't know how far this judgment is holding true, because many of, at least 90% of the hospitals are not having ventilators.
Yes.
To support the patient, and patient was referred to some other hospital, patient set up, and I don't know what is your opinion, madam, regarding this judgment?
Regarding the ventilators, no, for obstetric critical care.
Ventilators.
Yes.
And most of the 80% of the private hospitals not have ventilators.
Best is to develop all these labor rooms should be equipped with obstetric ventilators. Try to equip them with ventilators. And in centers where you don't have all this, best is to transport the patient as fast as possible to a center where all these facilities are available. So we are spending so much on ventilators, so why not have some ventilators for the labor room also, isn't it?
We have to equip ourselves.
Yes, sir. Yes, sir. Yes, sir.
Thank you, madam.
Thank you so much, sir. Thank you so much, sir. Thank you.
Thank you, ma'am. I call upon Dr. Vidya, ma'am, to hand over the certificate to Dr. Rajendra sir for chairing this session.
Coming to our next session, we call upon Dr. Baswaraj Patil, sir, Associate Professor, Department of Anesthesiology of our institute, to chair the scientific session by Dr. Ravindra US, Consultant Anesthesiologist, Derudong Park Medical Center, Bruni, Darussalam. Former professor and HOD of Department of Anesthesiology, Keshma, Mangalore, on the topic obstetric difficult airway.
Hello. So, good afternoon, everyone. So, our next speaker is a very well-known and very prominent name in the field of anesthesia. I'm very much pleased and honored to introduce Dr. Ravindra US, who is currently working as a consultant anesthesiologist at Derudong Park Medical Center, Bruni, Darussalam. To start with, the completed his undergraduate in 1987 from Government College, Ballari, and did his MD in 1993 in Karnataka Medical College, Hubli. Also did a DND in the same year. After completion of the DND, sir had various posts starting as a lecturer in Patil Institute of Medical Sciences in 93, then as assistant professor in Kasturi Medical College, Manipal from 94 to 99. In 99, sir joined ASAT Medical Academy, Mangalore as assistant professor, and then he stayed there only and became professor in head in 2004. And until recently he was there. Now he presently a consultant. He is working as consultant anesthesiologist in Derudong Park Medical Center, Bruni, Darussalam. Sir, apart from having the experience of giving anesthesia to all specialties of surgery, sir also worked as a locum anesthesia specialist at Vipas Hospital, Bruni for 1 year, which sir worked as a consultant to all super specialties except cardiothoracic surgery. Sir has a special interest or areas of interest of sir include difficult airway management in adults and children, pediatric anesthesia, pain management, and quality concept in anesthesia. Sir has conducted various studies, and these studies have been published in reputed good impact factor journals. Sir is a life member of ISA and Indian Association of Pediatric Anesthesiologists. Sir was the president of ISA City Branch, Mangalore for the year 2002. Sir also is a founder secretary of All India Difficult Airway Society, which was founded in 2010. Sir has been organizing secretary for various workshops and conferences, including the national level symposium pediatric anesthesia in 2002, 2004, and 2007. And sir is also organized secretary for 3 workshops during national annual conference of ISA at Mysore and Visakhapatnam in 2006 and 2007 respectively. And difficult area management workshop at Gujarat State Conference and at Nagpur in 2009 and in Karad in 2010. And pre-conference workshop for difficult area management at National Conference of All India Difficult Area Association in 2010. And difficult area management pre-conference workshops at SARC Anesthesia at Bangalore in 2011. Sir has been guest faculty for various regional, state, zonal, national, and international Cme programs, conferences, and difficult area workshops. To name a few, sir is a regular guest for ISA State Conference in 2003, National Conference of 2004, 6, 7, 9, and 11, City Conference 2005 at Mangalore, Southern Conference for ISA 2005, 6, 7, and 10, and Maharashtra State Conference at 2006. There is also faculty for workshops on fiber optic area management in the International Pediatric Anesthesia meeting at AIMS, New Delhi in 2006. There is also resource person for other conferences other than anesthesia conferences at a National Conference of Association of Oral Maxillofacial Surgeons in Mysore 2005 and National Conference of Indian Society of Cleft Lip Palate and Craniofacial Anomalies 2008 at Bangalore. There is also a research person for National Conference of Indian Society of Pedodontics and Preventive Dentistry in Bangalore in 2011. And annual National Conference of Cleft and Craniofacial Surgeons of India, Bangalore in 2012. So with this brief introduction, I welcome sir and
hand over the mic to him, and I request all the audience to listen to the topic, that is obstetric difficult airway, and take the maximum benefit from the session. Thank you.
Good afternoon. Can you hear?
Yes, sir. Yes, sir.
I can start?
Yes, sir.
Okay. Thank you, Chairperson. At the outset, let me begin with expression of my sincere gratitude and thanks to the Department of Anesthesia at BLDE, Professor Talikote, Professor Patil, and the entire team who have organized this wonderful CME with a very good team and very good speakers for giving me an opportunity to be a part of this one. And I also apologize for the inconvenience caused by my request to change the schedule because of like the inevitable things. So I'm happy that I could participate. So with that very brief lesson, I will go ahead with the topic. And to begin with, warm greeting from the place where I'm working with. That's called Jerodong Park Medical Center. It's in Brunei. If you can see, like I'm almost 6,000 kilometers from you, though I belong very much emotionally to Karnataka, and I feel I'm in BLD right now with you all. So let's move on with that. So this topic, obstetric difficult airway, just I would like to cover within the next 45 to 50 minutes with some time for discussion. Basically, this is the sequence I thought will go ahead. It's a very extensive topic, as we can imagine, like any other topic, like the other topics also. So I would like to begin with a brief introduction with some facts, and which include definition, incidents, etc. And the preliminary knowledge, whatever we need to, the outline of the preliminary knowledge we need to have for the understanding of the topic of airway management, particularly the difficult airway management. Then moving on to the preoperative phase, that is where the clinical part starts. So the priority is the clinical part. That's the preoperative phase, which includes assessment, planning, and preparation, proceeding to management with the inclusion or application of the available guidelines. So with that, I hope to cover in a nutshell or to provide a bird's eye view about the topic of obstetric difficult airway management. Incidence of difficult airway, whether particularly difficult intubation and field intubation, are higher, and of course the consequences are worse in pregnant patients compared to non-pregnant patients. This generalized statement, I am sure, will be agreed upon by every anesthesiologist who has seen both the obstetric and non-obstetric situations. So the definition of difficult airway, which is one of the commonest questions we ask the residents or everybody need to know, has been changed or expanded a little bit now. What I am giving here is the latest definition. It is a clinical situation in which anticipated or unanticipated difficulty or failure is experienced by a physician trained in anesthesia. It's basically applicable to the anesthesiologist. So including but not limited to one or more of the following. It's a broad definition or the common definition of the difficult airway. It's a clinical situation where both anticipated and unanticipated difficult airway are included. So all these components of difficult airway, that's whether it's starting from mask ventilation, laryngoscopy, ventilation using a supraglottic airway device, tracheal intubation and extubation, and invasive airway. In all these or in any of these areas, the experienced anesthesiologist will encounter difficulty. So the latest guidelines from the American Society of Anesthesiologists, the practice guidelines, you can see it includes the Indian representative from the All India Difficult Airway Association, Shaila Mayatra. It's a matter of pride for us. This is the first time the Indian Association has been included, and it's named as the second partner. It's a multinational representation of the various reputed airway organizations and airway societies. So next only to the American Society of Anesthesiologists, we can see the name of All India Difficult Airway Association. So now it is 2010. Within 12 years, we have reached this position. So with that, we will proceed. So difficult and failed intubations are higher, and it continues to be so. It was quite high from the beginning of the statistics. Wherever you see the literature, the incidence and the prevalence is higher, and it still continues to be so, though it might have been reduced in absolute numbers. So airway complications during different phases are possible. It's not just during induction and intubation, but till extubation, there is a potential or chance of airway complications, and these become important source of general anesthesia associated maternal mortality and morbidity. So if not mortality, which is comparatively less, morbidity, which can result in prolonged hospitalization, separation from the baby, increase in the cost, so many things can happen. In addition to the difficulty posed by the difficult airway per se, the time pressure and the need to manage the risk for two lives is what makes the obstetric airway management more difficult and more stressful for the anesthesiologist. In fact, it can be said, somewhere I read that it can be considered as a benchmark for the competence of the anesthesiologist. Of course, excluding those who are not doing obstetric airway, there are many other challenging areas as well. So now, just few facts. I'm just from the literature. Every pregnancy is a potential. There's a potential for life-threatening event in 9 months. That is something which is very, very, very true. You cannot 100% predict that any pregnancy can go ahead 100% uneventfully. So every pregnancy is a potential life. It is associated with a potential life-threatening event. And anesthesiologists are involved in the care of a significant percentage of these parturients for various reasons. I'm not talking about only general anesthesia, and 10 to 15% of the parturients in UK will need emergency cesarean section. So timing of delivery and probability of need for general anesthesia is not always predictable. So this unpredictability adds another dimension to the management of the obstetric difficult airway. So fetal distress or maternal complications over and above normal, what is imposed by normal pregnancy or even complicated pregnancy, there is an additional risk factor due to the sudden development of any fetal distress or maternal complications. Maybe bleeding, maybe systemic infection, sepsis, whatever it is. So anesthesia, especially airway management, is a stressful component of the entire care of the patient. So incidence of failed intubation is supposed to be, according to the recent article, that is Anesthesia 2020, Mushambi et al., which I feel like all those who are interested in obstetric difficult airway can read. Failed intubation incidence is per 1000 or 1:390 of obstetric general anesthesias. It may vary from institution to institution. This is an approximate number, and if the 390 becomes 500, it indicates a better care. Probably if it is consistently 800, still better, but it can definitely not be reduced beyond a particular point. Death rate is 1 out of 90 failed intubations, or 2.3 per 1 lakh general anesthesia, which is significantly less. This has happened over decades due to advances that have been taking place in the practice of anesthesiology and allied specialties. The difficult intubation is 1 in 21, which is very high obstetric patients versus 1 in 50 non-obstetric. So at least the double the possibility of a non-obstetric patient. So then this is a multicentric study which is recent 2020, published as a ASA abstract, frequency of difficult intubation obstetric patients, a study from the multicenter perioperative outcomes group research consortium in US, wherein multiple centers pooled their cases for analysis, which totally became, over a period of around 18 years or 19 years, it became 14,805 general anesthesia cases. Among the patients aged from 15 to 44 years, general anesthesia for cesarean. And they defined the criteria for difficult airway as difficult direct laryngoscopy or video laryngoscopy, 3 or more attempts, Cormack and Lehen class 3 or more, use of fiber optic intubation or supraglottic device or surgical airway, and failed intubation. Taking these criteria as the indicators of difficulty, they found an incidence of difficult intubation as 1.81% or 1 in 55, and this is less than what was found in the previous studies. This is from America only, a multi-center publication, and the previous one was less organized. It's based on the literature available, and among these many patients there were only 12 failed intubation and there was no maternal death. All were safely managed by various alternate means of airway management. Probably that reflects on the training, practice and the expertise available in the centers. So consistently the age more than 35, especially more than 40 years, BMI more than 25 and higher Mallampati classifications were associated with increased possibility or increased incidence of difficulty among this population. So they are anyway part of universally accepted and recognized predictors of difficult intubation. So now we'll just see what are the pregnancy-induced changes and how does it impact or how do they impact the airway management. Just in a nutshell again, so the airway, there will be change in Mallampati. That is obvious, like all of us know. From the second, all these changes start from around 20 weeks of pregnancy and continue to 2 days postpartum. That is usually the time duration what we say. And the changes in Mallampati from the percentage of those who have class 3 or class 4 become significant compared to the pre-pregnancy or in the first trimester when they reach the labor. Then increased vascularity, extravascular fluid accumulation, so tendency for edema, increased capillary fragility, all these things reduce the diameter and space of the airway, and which also results in the increased resistance to breathing. Along with this, the changes in the respiratory system, the position of the diaphragm, the FRC reduction, changes in the gastrointestinal tract resulting or predisposing to the risk of aspiration due to the changes in the lower esophageal sphincter and the orientation of the stomach and the breast enlargement, weight gain. These are some of the changes or majority of the key changes that happen in the pregnancy or during the antenatal period, which will have direct bearing on the airway management. So it is just a matter of the exaggeration of these changes or the severity of these changes when there is a complicated pregnancy. So oxygen consumption, presence of fetus. These are some of the issues which will affect the airway management. How do they affect? They affect by affecting the positioning of the patient. Patient cannot lie down easily and certain positions are not good, as we know, due to the risk of supine hypotension syndrome or aortocaval compression because of the difficult laryngoscopy, whether direct or video laryngoscopy, because of the percentage of increased difficulty intubation due to reduced visualization of the vocal cords, difficulty even with the alternate techniques, whether it is supraglottic device or surgical airway, anything, and the risk of hypoxia, risk of aspiration, fetal and maternal and morbidity. These are the final results of these complications or these changes. This is in a very, very brief, the key changes in the pregnancy which can have impact on the airway management. So this is something which is familiar to everyone, the different changes that occur from top to bottom. It's easy to remember if you go in a order. So whether it's the changes in the neck or changes in the breast size or the gastric position, I'm not repeating that. This is the changes in Mallampati. So there are contributing and compounding factors. One is the factors directly or per se related to antenatal period due to the changes in the hormone and growing uterus and the fetus. So the other set of problems is one is from the pre-existing difficult airway. May it be because of some tumor or because of some congenital malformation or syndromes, so on and so forth. I'm not going to details of that. or it could be due to comorbidities. The common comorbidity which will impact the airway management, one is obesity, irrespective of the upper part of the body is normal or thick neck or short neck, which of course will further compound the problem. The presence of diabetes mellitus, respiratory diseases, to name a few. There are a number of diseases which can indirectly affect the airway management. Added to that, the other factors, the expertise, experience, availability of equipment, and in obstetrics, particularly the timing of cesarean section, location where it is done, availability of help, and the urgency. So all these things will further compound and contribute to airway management or difficulty of airway management. So that is for the introductory part. The definitions, the incidence, we know that it's higher among the parturients, and the changes which are responsible for the airway difficulty. So now coming to the preoperative phase, this is where the clinical the work begins. So this statement I like: the more you sweat during training, less you bleed during war. This is, I think, something the resident should ingrain it in their mind. So more you work in a obstetric theater focused on this topic, more you'll be comfortable or less you'll be stressed when in future you encounter a obstetric difficult airway. So sweat more now, not because of the heat or anything, but because of your work. So get stressed, positively stressed now, so that your stress will be much less when you are qualified and encounter a difficult airway in a real life situation. So just to begin with the ASA, what I'm doing is I'm combining 3 guidelines in the description or in the steps what we go ahead. So one is the most recent one, ASA difficult airway guidelines, which according to the statement includes the obstetric patients also. The second is the Obstetric Anesthesiologist Association and DAS combined difficult airway guidelines for obstetric general anesthesia, produced by DAS in UK 2015, and the All India Difficult Airway Guidelines for Obstetric Patients 2016. So there are bound to be few repetition, few statements might be repeated. I think it's worth it. So I'm combining those 3 and proceeding in the subsequent sections of the pre-operative and perioperative management of the obstetric difficult airway patient. So the new guidelines say the assessment becomes more specific, measurement of the facial and jaw features. Then the anatomical measurements and landmarks. Measurements may be thyromental distance, neck circumference, or the thyromental distance to neck circumference, etc., etc. Then imaging with ultrasound and virtual laryngoscopy and bronchoscopy. We'll see more as we move on. Then the 3D printing is a new technology. So now India is developing so much that we cannot insulate ourselves from the changes that's happening around, saying that it's unlikely to be available with us in near future. With so many institutions coming up and everybody vying with other to improve the situation, so we might encounter, and even in small hospitals also. So this one is the DAS guideline. There's something called master algorithm, in which the first algorithm is the pre-induction, the safe obstetric general anesthesia. The first component of that is pre-induction planning and preparation, which is also included in the AIDA guidelines. So here they describe it as pre-theater preparation and plan with the team. You can see it's same: assessment, fasting status, antacid, and what is important is the intrauterine resuscitation. When you assess simultaneously, you can initiate the intrauterine resuscitation if you feel that there is a fetal distress and there is a reversible component of this distress. Maybe giving IV fluids, correcting acid-base abnormality, correcting hypotension, administration of the blood, correcting sepsis, whatever it is. So intrauterine resuscitation, then the plan with the team. So simultaneously, immediately after the assessment, you plan with the team. We'll come to that again in detail. So this is the guidelines for management of difficult and failed tracheal intubation in obstetrics. So next, so assessment, planning, and preparation. So this is a chain. Any weak link in any one of these things is bound to weaken your performance as the anesthesiologist in the obstetric difficult airway management. So obviously these are the known tools of the difficult airway assessment: history, examination, review of records and investigations. And you also need to look at the physiological difficulties and difficulty in positioning. So high risk pregnancy, especially pregnancy induced hypertension, has independent additional impact on airway. The same changes plus other changes. The presence of edema is more likely. There is a risk of convulsions. The coagulation abnormality could be there. So patient will have a high blood pressure. So your intubation will have further stimulatory effect on the hemodynamics, and patient can suddenly develop pulmonary edema during the course of airway management, so on and so forth. So pregnancy induced hypertension and similarly other obstetric complications also can have different effects. So when you have to diagnose the difficult airway during your assessment. How do you diagnose? You look at, assess and examine the mouth, neck, cervical spine with, like, for any diseases, tumors, infections, etc., by symptoms, history and physical examination, which already told, measurements, ratios, anatomical landmarks, etc., and their link with the comorbidity, whether it's related to that. Suppose there is a restriction of the cervical spine movement, so then it could be due to a syndrome or it can be associated with other anomalies also. So what's a key point that is recommended by the latest guideline is that it should be preferably done by the concerned anesthesiologist as soon as GA is decided and repeated before procedure. We all know that a complicated pregnancy, usually the obstetricians will take the opinion of the anesthesiologist, or at least it's a good practice to take or involve the anesthesiologist early during pregnancy so that you can track the changes. And if the same person is able to come subsequently, the quality of care can definitely be better. So preferably the assessment must be done by the concerned anesthesiologist. So this is a classical triple field syndrome where there is a fusion of the vertebra. Like a lot of aspects of airway management could be difficult. You cannot position comfortably. You cannot do laryngoscopy easily, the direct or video laryngoscope. Supraglottic devices may be okay. So tracheostomy will be extremely difficult because of the fused vertebra and short neck. So if you see here, predictors of difficult airway and the impact on specific techniques. So for example, if you see the BMI, when the body mass index is more than 35 kilograms per meter square, all the techniques, whether it is face mask ventilation or intubation or surgical airway or supraglottic airway, or the same with the neck circumference more than 50 centimeters, can all be difficult. So that's very, very important. And thyromental distance less than 6 centimeters, depending on how less it is, the surgical airway may or may not be difficult. So mouth opening, again, what is said is ideally for direct laryngoscopy, more than 3 fingers or 30 millimeters, more than 25 millimeters for a video laryngoscopy. So less than that will be extremely difficult. So one device probably when it is extremely less, when the mouth opening is less than 25 millimeters, one device that can be useful is the lighted stillets. They can be used, something like track light and others. So Shikani stillet, etc. And then Malampati higher grades, again face mask ventilation and intubation, but it need not affect the ability to insert the supraglottic airway device. So fixed spinal flexion deformity, definitely surgical airway. So is difficult, and obstructive sleep apnea will cause intubation difficulty and can cause face mask ventilation. So this is one of the associated features of obesity. So then poor dentition, airway edema, reduced jaw protrusion, huge thyroid. You can see good number of case reports, or at least few important case reports where pregnant patients have presented with huge thyroid, even with obstruction. There are case reports where the cesarean was done under epidural, followed by the fiber optic and then thyroid surgery in the same sitting. So many combinations are possible. Then snoring, that's a way in OSA. So next is the next component. You have taken the history, assessed, reviewed the records, and then the advanced investigations, airway imaging, which is becoming rather basic. The part of the imaging is basic now, part is advanced. If you look at the ultrasound, it becomes almost a basic investigations or assessment tool, and the MRI, CT, and the other virtual imaging techniques are the more advanced ones. They are also used for the ultrasound is also used for confirmation of intubation, and the structures we can see through the ultrasound are vocal cords. You see the various structures, whether it is tongue thickness or vocal cords or the different measurements, the tracheal diameter, etc. With that, you can assess preoperatively the nature of the difficulty, the size of the tube, the level of obstruction, if any. You can direct the tracheostomy if it is being done awake by identifying the ring, and it can help to prevent the injury to the posterior wall. So only thing is we must know the basics of sonoanatomy, the technology of the ultrasound, and the techniques of ultrasound. These are the two very, very useful articles. This is, for example, ultrasound. This is, I think, 2011, if I'm right. I think I'm wrong here. So ultrasound of the airway, one of the, I think, most beautiful and very, very well written article by Dr. Pankaj Kundra and team. We all know how great he is in this topic in presentation, and role of operator airway ultrasound in airway management in critical care. So I think these two articles together for a resident will give lot of information about the sonoanatomy and the clinical applications of the ultrasound. So this is the more interesting part of the virtual imaging techniques, virtual laryngoscopy and virtual, see, these are all different laryngoscopic and virtual bronchoscopic picture, wherein using the software and based on the static CT series of static images, they reconstruct the whole passage of the airway so that you don't have to do the invasive endoscopic examination if this facility is there. Maybe certain indication will still be left, but by and large, it can reduce the need for the invasive endoscopic investigations, which may not be always easy, both in terms of the availability, expertise, and patient comfort. So virtual imaging might largely replace the real endoscopic assessment preoperatively. So ultrasound, CT, MRI, and the X-ray, the humble X-ray, which still has withstood the time, can be helpful in knowing the spine and knowing the soft tissue anomalies, the tracheal deviation, etc. So after all these things, it's very important. I'm not talking about the emergency. Whenever time permits, so it's the responsibility of the system that the emergency cesarean deliveries or the cesarean sections are minimized. So as many as possible are done on an elective basis where the patient's airway is assessed and prepared. So one of the parts of preparation is a multidisciplinary consent and patient involvement in decision making. So all these specialists can be required or involved depending on the institutional practices, department protocols, and the availability of the expertise. So multidisciplinary consultation and consent is a very important part of the assessment. So the assessment would have led to presence of difficult airway, and this has to be followed by planning. So what do we plan? So in the general statement is that in obstetric general anesthesia, endotracheal intubation is the most common airway strategy. So much so that you can call it as gold standard of airway management in obstetric anesthesia. Presence of a cuffed endotracheal tube in the trachea gives protection like no other technique in obstetric patients and prevents aspiration to the minimum. Rapid sequence induction intubation is the most preferred technique to achieve the above goal of intubating a obstetric airway. Rest all are exceptions and alternates to this primary. So this forms probably 80% or 75% of the techniques of airway management and the approach of airway management. So however, other options for endotracheal intubation or alternates for endotracheal intubation, as well as what we can call non-intubation general anesthesia options should be included in the planning. NIGA includes use of supraglottic device, tracheostomy, face mask, cardiopulmonary bypass also. So there remains a small percentage of the extremely difficult airway where none of the conventional techniques will be of use, including the surgical airway. The classical example is one is extreme distortion of the head and neck anatomy with no scope for surgical airway. Second is mediastinal mass, huge mediastinal mass, which could collapse the airway the moment you do anything else. So then the planning should include the information to patient about the difficult airway, the discussion about the plan in a non-threatening way, and patient's doubts. So it should include the techniques, drugs, equipment, sequence, and oxygenation. The sequence is very important. We may have 100 equipment in our department and you can keep everything ready. The entire difficult airway could be very well organized. But unless you have a plan in which sequence you want to use, what we tend to do then otherwise is you ask for one thing, before that comes to your hand, we will ask the assistant to give another thing. So finally, it will lead to chaos. So that sequence is very important. Then backup and alternate plan at each step help, and we'll talk more about the help and the human factors. Then extubation and post-operative care is very, very important. There's one series of the cesarean related cesarean GA related deaths where it is mainly due to the extubation. 5 patients died almost in a series in Michigan, I think, in Michigan, in USA, due to the extubation related complications. So monitors, ultrasound for the emergency help for assessing various functions of the airway or dynamics of the airway. Emergencies, this is called the being prepared directly, the surgeon washed up and being prepared for surgical airway while you are attempting intubation from above is called double step intervention strategy, and it is a suggestion by the Canadian Airway Association. Teamwork with specific roles assigned, it is very, very important. Just saying that yes, we have a team and who knows who know the or who are all experts is not the correct answer. Each person, however expert or not so much expert, the specific role for that particular patient is more important. Even if a person is an expert while another person is doing or leading the team, this person will have to play the role of the team member. So additional equipment and expertise as needed. So techniques, you have the mask ventilation, supraglottic airway device, endotracheal intubation, either with direct laryngoscopy, video laryngoscopy through supraglottic airway device, or flexible, or there's something called hybrid techniques or combined techniques, which must be considered in any anticipated difficult airway and even in unanticipated difficult airway. Then the possibility of need of surgical airway. So oxygenation planning, we'll see that again, and the risk of aspiration should be carefully assessed. Appropriate prophylaxis and arrangement must be made. So drugs and equipment already so possibility of failure, complications, and need for additional help. So this is the mechanism of desaturation during intubation, which explains the need of oxygenation. If you see, low SpO2 can develop due to either low oxygen storage or increased apnea duration. So in pregnancy, there is a tendency for low oxygen storage, both because of the reduced reserve and increased VO2. Low reserve is due to low FRC and with comorbidity, if anything present. Increased VO2 is due to pregnancy. Added to that, if there's a fever or something, then it can cause worse. And obesity will also worsen the low FRC. So one important determinant of low SpO2, that is low oxygen storage, is very much affected in pregnancy. Added to that, if we increase the apnea duration by not planning or by encountering face mask ventilation difficulty or contraindications, presence of contraindication face mask ventilation, or because of the full stomach resulting in gastric distension and impeding the ventilation, or improper positioning of the patient, flat patient if you keep instead of putting patient or positioning head up, or mask leak, etc., you will immediately lead to desaturation. So we need to take into consideration when you plan for oxygen, it should be a separate plan which should be integrated with the airway plan per se. Airway plan means to place the airway device and to control and protect the airway and to maintain the airway. Oxygenation plan includes the airway plan plus something else to manage oxygen from the beginning of the procedure when you have not yet intubated to the point of confirmation and connection to ventilator and giving the first breath. Till that, your alternative oxygen plan should be available and should be working. So comorbidity, pre-oxygenation can be inadequate if the patient is restless or bleeding or non-cooperative, etc. Patient can be it can be inadequate. So you need to keep that in mind. Then rarely a patient from ICU will also come for oxygen, particularly the eclamptic patients. Already this topic would have been discussed. Then multiple attempts also will compromise the oxygenation due to edema, hemodynamic instability during management. So the choice of drugs, the way you administer the drugs, preloading, uterine displacement, they all indirectly contribute to measurement or maintenance of the oxygenation. So measures to prevent hypoxia should be implemented before SpO2 falls. This is what the period of called complete ventilation failure, first time used by the All India Difficult Airway Association. That is complete ventilation failure, a brief period of time which occurs by the time, from the time you are not able to ventilate with mask or after failing intubation till the time the SpO2 really drops. So that is because of the stored oxygen, whatever is available. So if we are using these techniques, what we call so now the terms are pre-oxygenation, peri-oxygenation, they are also called para-oxygenation, and then actual intubation followed by ventilation. So this, if you, the apneic oxygenation techniques, where during apnea you ensure that there is a continuous mass flow of oxygen, then the risk of hypoxia is significantly reduced. Consequently, the period of safe apnea is significantly prolonged. So they are nasal oxygen, low flow or high flow. High flow is better without anything else, or the Thrive, as we all know, no desats. Let's see, nasal oxygen during attempts at securing the tracheal tube, then the pharyngeal insufflation, even transtracheal. Sometimes we give local for air ventilation. You can keep the cannula in place and insufflate oxygen through that. So that also produces some. So this is the transnasal humidifier, high flow. This is the high flow oxygen therapy, apneic oxygenation. Then this is one thing, supraglottic oxygen therapy. So here V jet and V nasal jet tube, these are the two equipment which are quite useful. If you see here, you can provide jet ventilation through this, and you can also, the nasal and oral one, you can just position it at the entry of the glottic. That's a supraglottic jet ventilation. This can be life-saving, and it also measures the carbon dioxide. You can measure the end-tidal carbon dioxide also. So this is something which can be included in the preparation. If so, other issues are respiratory compromise. There can be a set of pregnant patients who can present with respiratory failure for cesarean section. So complicating that, if there's a difficult airway also, then you must really plan double the planning what you normally do. It could be because of the eclampsia, it could be because of obstetric or non-obstetric sepsis, then perioperative cardiomyopathy, which is a rare complication, or amniotic fluid embolism, or aspiration has occurred subsequently you are managing the patient, or patient has got an exacerbation of the asthma, or a patient has got unfortunately the transfusion related lung injury. So all these patients will present for cesarean section under general anesthesia with the severe respiratory compromise. So then the other thing is the personal to document and monitoring. So there's something new term they have introduced in the difficult airway algorithm or the guidelines, that's called stay time. Like somebody to monitor the time. The person who is doing the procedure may not be able to mind the time that is passing, and each passing minute is something which is very, very dangerous for the patient unless it is planned in a perfect way. and the number of attempts to limit should be limited. Again, every time we think that next time I will succeed, and we keep on attempting in spite of just before that hour, if you have discussed the difficult error guidelines, number of attempts, we can come and do the same mistake, all of us. So those have to be reminded. These are all cognitive, probably the stress reflections or reflection of cognitive stress. Somebody should be there responsible to remind the time, to remind or keep track of the number of attempts, and to monitor the SpO2. So if you go for the infographic of this 2022 algorithm, what it says is for adult patients, we may not be able to see. It helps to make a decision between the awake and anesthetized, non-invasive and invasive. This is the first decision one has to take in a difficult airway. So this is pre-airway management decision-making tool. So suspected difficult laryngoscopy or intubation, if it is yes, is ventilation difficult or easy with face mask or supraglottic device? If that is also difficult, is there a risk of aspiration? Yes. Then is there a risk of rapid desaturation, the physiological component? If the answer is yes for all the four, then awake airway management. You see here, awake is the indication for awake are some of the indications reflect seen in the literature are extreme obesity, some HELP syndrome, mediastinal mass, swollen tongue, reduced mouth opening, local anesthetic insensitivity, very, very rare condition, extremely rare condition, a joint hypermobility syndrome, then massive thyroid swelling. These are all some of the indication for awake techniques. And awake technique does not necessarily mean only fiber optic or surgical. It can be video laryngoscopy. There are case reports with direct laryngoscopies with simple application of the local anesthetic gel to the blade. They have done awake intubation. So if it is anesthetized, so if not awake, it is anesthetized. Then anesthetized, again, you have the aspects to decide whether DL or VL. Since nowadays the advocacy is for the using the video laryngoscope as the first choice, because it will increase the percentage of first attempt success rate. It will reduce the overall number of intubation attempts, and it might reduce the trauma to the airway. Some of the aspects are not proved through randomized control studies, but definitely overall success rate is higher with video laryngoscopy depending on the training of the performer. Then the flexible or combined technique. You can combine direct laryngoscopy with FOB or video laryngoscopy with FOB or supraglottic airway device with FOB or a lighted stiletto. Any combination, you put one side one set of techniques, the other side other set of techniques. You can combine them and make it a hybrid technique and get the best result for the patients. So SAD, is it a primary device? Very rarely there are case reports where electively they have used the second generation supraglottic airway device as the primary airway for cesarean section in a well prepared situation. Otherwise, by and large, it is a backup. Then spontaneous, are you going to abolish or preserving? Celix maneuver, then what is the plan is already discussed, and surgical airway. So this is also done. So surgical airway, some of the indications are failed non-invasive techniques or as the primary choice. So it could be because of subglottic stenosis or spinal muscular atrophy or history of failed intubation, and this indication, that is a elective tracheostomy for a cesarean section or even before normal delivery, to reduce the work of breathing, because patient is on the edge of developing respiratory failure either due to neuromuscular disease or some other reasons. Then you do a tracheostomy under local anesthesia, then proceed with the labor or cesarean section under regional anesthesia. So this is also a type of airway management. So this is one more the dimension of the obstetric difficult airway management, or a patient airway management in a difficult patient because of the respiratory compromise. So this decision making too, that is the location, timing and teamwork, very, very important in obstetrics, of course now in any critical area, so to prevent crisis. So consider facilities during off hours in terms of equipment and help. So whatever is available during regular working hours need not be available later. So you have to be careful. Then special needs due to nature of the difficult airway. So you have to schedule during regular working hours if possible. Still a percentage will come for emergency cesarean and use of specialized locations like cardiac theater, etc. So that is also possible. Then the sources of complication, these are all the sources of complication, patient condition, equipment, etc. So antenatal planning, so patients are included in decision making. Now we will go through the last important point. When you have spent enough of time in these two parts, what we have already discussed, then this becomes more safe. So prepare for difficulty and failure, small size endotracheal tube. These are the steps what we all know. That is modified rapid sequence induction intubation, then induction, prepare for modified rapid sequence induction, then induction, scoline or other muscle relaxant, gentle ventilation, video laryngoscopy may be the first choice, confirmation. So we'll go into details of the step 1. Head up is the common preferred position with pelvic tilt. Then IV access preloading monitors. This monitors is very, very important. Pre-oxygenation with vital capacity or tidal breaths. You decide what sort of pre-oxygenation you are choosing. Prepare for apneic oxygenation, nasal or pharyngeal, and then explain the cricoid pressure. And this is the ramp position is important for the obese patient. Then for convention modified MRS, that's MRSI is what we commonly use. Modified rapid sequence intubation, where you are using this sequence. You choose propofol over thiopentone. Thiopentone was a part of classic RSI. You can choose atomidate also. You can use a fixed dose or titrated dose instead of fixed dose, which is a part of classic this one. Start cricoid pressure, which you can release or reduce during the laryngoscopy or supraglottic airway device, which is again a deviation from the classic technique. A relaxant can be rocuronium, or even if you don't have rocuronium, atracurium also as a deviation from scoline. Gentle mask ventilation, which is also another modification. Then intubate and mask ventilation in between the attempts. So connect and ventilation and release CP. So optimizing the success, this is what the difficult airway guidelines say. Reducing or removing this is the first attempt, you must make it optimal. So the moment you anticipate difficulty, you ask for the bougie, or you can directly position the head and neck before if you anticipate difficulty, or optimal external laryngeal manipulation. So once you succeed, you confirm. If you fail, go for the second attempt with mask ventilation in between. That's a very, very important. The proper application of the cricoid pressure and understanding the difference between this cricoid pressure and the external laryngeal manipulation is very, very critical. So then second and third attempt is done according to the DAS guideline with the alternate laryngoscope and removing the cricoid pressure. If you fail, then it becomes a failed intubation. At this point, if you see the Indian guidelines, it says when you encounter difficulty, unable to intubate with the first attempt, you continue nasal oxygen, more specific, with flow of 15 liters, only 2 attempts, whereas in DAS guideline, it is 3 attempts and the 4th attempt with the expert. And here, the only one more attempt if SpO2 is more than 95%, and the partial, this is same, cricoid pressure is same, and changing the device, technique, operator, etc. Maintaining the depth of anesthesia is a very critical part whenever you are continuing the attempts of laryngoscopy. Otherwise, hemodynamic response and awareness are the laryngospasm are the complications. So failed intubation here, supraglottic airway device, there also supraglottic airway device. So here, both places they favor the second generation supraglottic airway device. And in this the algorithm 2, it is called here, it's called step 2. So maximum 2 attempts, both guidelines, and consider changing the size or type of supraglottic device. That is the Indian guideline. So maintain, there are few points which are very beautifully incorporated in our Indian guidelines in each step, making it more specific. And call for help. It is a continuous process. From the moment you recognize difficult, you need to call for help. So here, if you see, say oxygen is the priority. Once you declare failed intubation, so you think of two options alternating between the two, supraglottic air device and face mask, where two-hand ventilation and removal of CP may be required. And depending on the success or failure, you activate, if it is failure, you activate the CICV algorithm to prevent it becoming CICVCO. So when there's a adequate oxygen with these somehow managing the airway efforts, so you either think of waking up or proceeding. So CICV algorithm is declaring emergency, calling for help, look for laryngospasm and the neuromuscular blockade, and front of neck procedure, which the IDA guidelines specifically says what you have to do about the it says specifically emergency cricothyrotomy while continuing the rescue face mask ventilation with the final attempt with the adjuncts like the airway, etc., and surgical cricothyrotomy or wide bore cannula cricothyrotomy, etc. If it also fails, then go for perimortem cesarean section. So here again the perimortem cesarean section or maternal AC with maternal ACLS with the difference what are required for that. So then this is the combination of all these factors by the difficult airway guidelines 22. It's available freely in the net. Here again, see non-emergency pathway, emergency pathway. As far as possible, you have to achieve the success in the non-emergency pathway. So only less than or equal to 3 plus or minus plus 1 attempt is what it stays. Stay time, attempt, and SpO2 aware. And if you see the vortex approach here, vortex approach, if you remember, there are only 3 devices which you can use for non-invasive management. That is the supraglottic air device, face mask, and endotracheal intubation. Mask is always for in between the attempts or sometimes desperate attempt to maintain oxygenation during the cesarean section. Supraglottic air device primarily as a backup for the intubation. Intubation is the preferred choice, but not always possible. Backup for all these things is the surgical airway. When all these things are invasive and non-invasive not possible, then the ECMO or the CPB, and one more equipment which might be helpful is the rigid bronchoscopy, particularly in the mediastinal mass. So waking up, maintaining oxygenation, continuing CP while waking up. This is a critical, even if you decide to wake up, it's not an easy, let's say table in DAS guideline. If patient is stable, if the SAD what we have used is a first generation device, if the fetal distress is not present, if mother is stable, you can think of waking up the patient, not you might have to proceed. So after wake up, you decide what you have to do. If you need to repeat GA, you make the additional preparation, then go ahead. And during recovery, there's a potential for CICV-CO is for cannot oxygenate, and awareness must be prevented, treat or prevent laryngospasm. Proceeding with surgery, either anesthesia or spontaneous relaxation, that is same questions again come for the second round. So if you're proceeding with surgery without the intubation, minimize the fundal pressure. If you used a supraglottic airway device, empty the stomach and H2 blocker if not given previously. So now the last part is unanticipated emergency difficult airway. So call for expert help, optimize oxygenation, waking up, use cognitive aid. This is where you have to use the cognitive aid. Let's just think of the vortex approach. That's the best cognitive aid probably I can say. And vortex approach and the non-invasive air management sequence of use of equipment, combined techniques, invasive air. These are the part of what we can call crisis management. Most important is the airway control, prevention of aspiration, maintenance of oxygenation, and think about the fetus and the mother's well-being by continuing or waking up. Which option is better? So extubation, again, we know the 4 P's: plan, prepare, perform, and post-extubation care. Proper timing, adequate reversal and recovery, plan for extubation and extubation, re-intubation. Like rather post-extubation, re-intubation. So unless you are prepared for re-intubation, should it be required, I think your preparation for extubation is not complete. Consider special techniques like extubating over a flexible bronchoscope, or a gradual extubation. You can extubate over a airway exchange catheter also, or the Bailey technique, that is, you replace the endotracheal tube with the supraglottic device, which really requires experience to do that. Then document, explain, and communicate to the patients. This is the emergency airway cognitive the tool. So here, if you see the intubation, supraglottic device, face mask, and for each there's a manipulation of the head and neck, larynx, and manipulation of the device. The Candice maneuver, you can remember the up and down, which was described for the classical MA. Then use of adjuncts, especially for endotracheal tube, whether it's a bougie or a stillet or a lighted stillet or a video laryngoscope, whatever it is. Then change the size and types, whether first generation to second generation, smaller to larger size, suction and muscle relaxation, etc. So cannot intubate, cannot oxygenate, surgical quick. To summarize, say difficult airway in obstetric patients is more frequent, consequence of less than optimal. I don't say wrong management, because most of us always do the things in a right way, but it may not be optimal always, especially when we encounter conditions which we do not ordinarily encounter. So suppose a very obese patient, asthmatic, who also has got a bleeding, yes, definitely most of us would find it extremely stressful and difficult to manage, and performance can contribute to maternal and fetal morbidity and mortality. The assessment, we must identify the predictors and assess the risk versus a risk versus a different technique, with one technique with the other, oxygenation and other contributory aspects, including human factors. Advanced workup with imaging, multidisciplinary consultation, and use of bedside focused ultrasound. So focused airway ultrasound is very important. Then the planning should be, or it's also called point of care ultrasound, that is POCUS. This focused ultrasound is called POCUS. So planning should include timing, location, team, and in addition to routine established difficult airway strategies. So what is important is, when it is a difficult airway, first you adhere to the difficult airway guidelines and the protocols and the accepted norms. Second, incorporate the pregnancy related factors into the same planning. Oxygenation and aspiration prophylaxis should be a part of the plan at all the times, when elective, when in emergency, when there is an unanticipated difficulty during extubation. Then guidelines can be used with suitable modifications tailored to the individual situation. So guidelines are not God-given sermons or mandates for us to follow. It is there for the professionals to be guided in a right way, to miss not to miss the important or critical steps. So to that extent, guidelines are very important. Beyond that, yes, your opinion, your seniors or your lectures, the colleagues or teachers' opinion or expert opinion is always very, very important, especially when you manage in a low resource setting. So plan for failure management is a very important part. Any technique can fail. Also, if one technique fails, this is very important. Risk of failure of other technique is high. This is shown by the literature, not by my statement. If a difficult laryngoscopy is encountered in first 2 attempts or something, your supraglottic device also could be difficult, or video laryngoscope also can fail. So then careful and informed choice should be made between awake and asleep, non-invasive versus invasive approaches. Importance of human factors, dedicated person to keep track of events and remind the time is extremely essential. Formal plan with anticipation of difficulties and failures based on individual situations. And intubation is the standard airway technique, but other devices and other techniques should not be forgotten. So just another one slide, I think. Failure of first attempt of intubation should alert the system for potential failures in subsequent steps. Call for expert help, 100% oxygen, optimization of ventilation, prevention of aspiration are among the key components of crisis management. CICV and CVACV-CO should be prevented and managed aggressively if developed. Remember the window period of complete ventilation failure, wherein the SpO2 still maintain or hold on like it holds on. So that is the time when you immediately initiate the measure. Extubation should be planned. And lastly, any airway crisis or major complication should lead to a healthy discussion and root cause analysis to plug the loopholes and strengthen the system. So just a few words. I've taken permission from Vidya Madam. Just a few words about the this book by me and Professor Nalini Kotaka. That's the Anesthesia Residency Manual. I request all of you to support this, and I feel it should be useful for the residents to manage the residency in a most effective way. It contains about 25 chapters, about 220 pages, all abstract topics, not per se anesthesia, most of them, but what is required to make the best of your the residents 3 years period, including how to study, then the how the anesthesia has reached where we are now, the knowledge of allied subjects, etc. These are some of the contributors and some of the chapters here. So these experts' advice, they all have given their perspective on in a very brief way about the residency. And the last one is a surgeon and the dean of the institution, Dr. Srinivas M. So different perspectives about the residency or advices to the residents are incorporated. And the self-assessment tool probably is a very important one for me. Like the formative assessment, the residents can assess themselves every 6 months how their progress is. So it is meant to be individualized, just like we used to possess the Hutchison or the manual, clinical manual. Our vision is that this book should be possessed by individual resident so that they can make best use of what is there in that. Thank you again for giving me this opportunity and listening patiently. Thank you.
Thank you, sir. Very informative and very insightful, especially the USG using airway assessment, virtual bronchoscopy and virtual laryngoscopy. Nice. Now, we can ask questions, sir, regarding supraglottic airway devices. Hello?
Hello?
Hi, sir. Supraglottic airway devices, which one we should be preferential order to be in emergency?
Somehow the audio, I am not able to hear very clearly.
Now, sir, hello?
Can you just the message be typed quickly for me in my mobile? I can see that easily.
Sir, now, sir, hello?
Yeah, hello?
Sir,
Hello?
regarding supraglottic airway device,
Yeah.
which one should be preferable, like classic or a procedural or this one, ideal, which should be preferential order?
Yeah, this part, no, this is actually a good question, but the thing is probably there is no clear answer, or one will be like, no, you can't say one is superior to the other. It is the experience of the person is probably the most important factor, and the common factor is second generation supraglottic airway device.
Yes, sir. Yes. Thank you, sir.
And if you have any specific purpose like intubation through supraglottic airway device, then definitely the ones like Procil or the ideal may not be an ideal device. You have to choose something like the AirQ mask or things like that, intubating LMA, etc. Intubating LMA nowadays is not much used. So you have to use a specific device meant for facilitating the intubation. So otherwise, anything second generation supraglottic airway device is fine.
Yes, sir. Thank you, sir.
Yeah.
Any questions from the audience?
Good afternoon, sir. It was an excellent talk, sir.
Thank you, madam.
Sir, I just have one query, sir. Sir, you mentioned about 3D printing. Could you please elaborate on it?
Which one, madam?
3D printing.
Oh, 3D printing, I also cannot. I'm not very sure about the technology. Very sorry. Actually, it is not only 3D printing. The artificial intelligence is also coming to difficult error management in a big way. So they can detect the various abnormalities and they identify the nature of the difficulty. So with this, they're all based on this artificial intelligence applications. In one of the recent journals of pediatric anesthesia 2020, so they have a lot of things about this artificial intelligence application in airway management. So I'm sorry, actually, I am not, I don't have much idea about that.
Sir, I would like to say certain things about this, sir.
Yeah.
This will not be applicable in one single patient. Like 3D printing of a patient's airway in one patient is not going to helpful, sir. We'll have to, I'm not very sure of this, sir, but I still want to express what I have read it somewhere. You go on taking 3D prints of the airway as you pass on your video laryngoscope, and then using the artificial intelligence, you amalgamate all the information that you have got from different airways and come to a conclusion. So this can help you to manage difficult airways in certain situations. If you go through this, this might help you during one particular difficult airway situation.
Yeah, okay. You mean to say like it's a post-procedure phenomenon, like no, you do after the procedure, after you encounter the difficulty, or in a recognized difficult series of patients, you do that and get a picture.
Yes, sir.
I'm not very sure. Must be like at present. But the thing is, I'll just one interesting analogy in this context. No, our anesthesia residency manual. So initially, when I was discussing with a local printer, he said minimum some 200 copies or something. Otherwise, it will be very expensive, or 100 copies. So now, what these publishers, like some other publishers in Delhi, whom they are printing, they print even one book and give on order from Amazon or something. Next day, the person will get. So earlier, we were not able to think of printing one book and selling it at all.
Yes, sir.
So probably as the technology progresses, it must be possible to get even a single person. Just like the virtual bronchoscopy and virtual laryngoscopy is possible, it's meant for individual patient. Maybe that is what you are said. What you are telling is currently probably that is the correct status. But with the changing or improvement in the technology, probably it should be possible.
Okay. Thank you, sir.
Yeah.
Thank you. Yes.
Is associated with increased risk of aspiration. How safe is it to use supraglottic airway devices? And can we conduct safe delivery using SAD without compromising on the fetus?
Without compromising?
On the fetus.
Without compromising of what? Sorry, it's a lot of disturbance. You are asking, is it safe to use a supraglottic airway device when there is a risk of aspiration, right?
Yes, sir.
Then second part is?
Conduct the delivery.
Breaking, voice is breaking fully.
Sir, how safe it is to conduct the delivery with the supraglottic airway device without compromising on the fetus?
No, supraglottic airway device, basically, as I was telling, there are only two primary, as a primary device, and the first choice only when conditions are very, very optimal. Like the risk presence of difficult airway, you don't want to intubate for some reason, either because of lack of expertise or anything, but patient is thin, well prepared, fasting adequately, so second generation supraglottic airway device, that is fine. The emergency is life-saving, and there's something you will have to do. So with that motive only, you will have to use the supraglottic. Even if there is a risk of aspiration, you protect the airway to the extent possible by using a supraglottic device, and then emptying the stomach, bypassing a nasogastric tube. That's what I feel. There's no other option. Like when there's nothing better than that, then you choose it as the backup device.
So we have another question. So how safe is to include glycopyrrolate and a pre-medication in a pregnant woman, as the risk of aspiration is already increased? Won't it the gastric emptying is also increased? So how safe is to include glycopyrrolate in a pre-medication, sir?
Glycopyrrolate pre-medication, anyway, why do we need it? If at all you are giving, if you give intramuscular, I think the clinical impact, at least adverse impact, is very, very minimal, hardly anything. So IV glycolate also, pyrrolate also may not be very harmful, But I usually rarely use glycopyrrolate for these things, not required most of the times. If there's any possibility of using, I prefer to give intramuscular.
Thank you, sir.
So,
Thank you, sir.
Sir, one more question.
Hello, sir. How exactly to assess for the record pressure, sir, in cases of rapid sequence intubation?
record pressure in case of?
A rapid sequence intubation, sir.
Yeah, but record pressure now again it's fairly clear the stand you have to use, or you should preferably use the record pressure at least for medical legal purpose. The benefit of record pressure are neither the beneficial effects nor the important complications are proved conclusively. So it is something which needs to be used as a routine more than a real benefit. And the very clarity is in the recommendation that in case it interferes with the laryngoscopy or video laryngoscopy or mask ventilation or intubation, then you reduce or release. That is very clear. But regarding the use and benefits, it's not very clear. You better to use it because of the medico legal implications. But it must be reduced or released in case it's interfering with the airway management. That is also clear.
Okay, sir. Thank you, sir.
Yeah. Thank you, sir, for taking this one time. Thank you once again.
Thank you everyone for the opportunity. Have a nice day. Thank you.
Now I call upon Dr. D.J. Talikoti, sir, to hand over certificate to Basraj Patil, sir, for chairing the session.
Our next section will be starting by 2:45. So I cordially invite everyone for the lunch, which has been arranged in the same floor, the demonstration room, next to the medical records room. So after 1 hour, we'll again meet again for next session. Thank you.
For lunch. How much?
So many. I will make
So many. Doesn't matter. Only 1 hour you stand up. I want 1 hour like 15 minutes. How slides you have to on this slides. Yes, 50
Yes, sir. Yes, sir. Now let's resume the session. Now we call upon Dr. Pandit Dhyaneshwar Hari, Senior Consultant Anesthesiologist, Vijayapura, and first HOD of our department, to chair the scientific session by Dr. Shripad Mehendal, Professor and HOD of Department of Anesthesiology, Critical Care, Case Hegde Medical Academy, Nitte, deemed to be University, Deralakatte, Bangalore, on topic perioperative coagulation disorders in pregnancy.
Hello. Good afternoon, everybody. This is for the session. Very difficult job you are going to do because most of the people will be anxiety, sleeping mood. Doesn't matter. I would like to speak few words out of my practice. If allowed. See, this is 38th year of my practice in anesthesiology. I am mainly practicing anesthesiology in Vijayapura, started in 1984. And from 88 to 93, I was in charge head of department of anesthesia department. Those days anesthesia was very good, no monitors, no gadgets. And in last 38 years, I have come across so almost every day I gave anesthesia to civilian. And many times I have come across patients with various types of disease like APH due to placenta previa, abdominal placenta, septicemia due to that is intraoperated and retained for a long time. So like that patient will for traumatic, post-operative APH. So many, and sometimes I have given anesthesia, you may not believe it. I have given anesthesia for patient with 5 to 3 gram HP. Believe me, because I am very much practical oriented. Maybe we have to know, you have to be scientific. When you go to the rural place with minimum facilities, and our intention is to save the life. So sometimes it has happened like that when the organization wants to issue patient to the higher institution. I used to object. I am an anesthesiologist. I will do anesthesia. Don't shift patient. Why? Because in the process of shifting and taking patient to causality and their formality, patient will die. We will try to save patient with patient. And like that, so many patients also I already have given propofol and intubation. Then I used to call one more obstetrician on my own. And if the bleeding is preventable, okay, they used to ligate and prevent. Otherwise, I used to say, as a team leader, you do hysterectomy. Because jama hai to jama hai. Life is more important. So like that, it has happened. And fortunately, with God's blessing, every time I have been successful in treating the patient. To start with, I thank Madam Vijayapura, HOD, Dr. Vijayapura, half of my department, and all the guests for giving me this privilege to be on this seat, because nowadays diabetes has become less. Because I'm practicing person, and in last 2 years of COVID, I will concentrate more on COVID patient and treated online also. So this is also one of the main job for any company. And so many these things have happened. Thank you, madam, for giving me the opportunity and honoring me today, chairperson of this session. I am very happy to introduce a great personality, Dr. Shri Mahanagari, MBBS, MBA, PGD. He is born in 1968, married to Dr. Umang Kulkarni. Now he is a professor, head of Department of Critical Care, ASFD, Medical Academy, Coagulation Research Center, Mangalore. He has got many qualifications. He did in 1991. Diploma in Anesthesia in 1994 from Mysore Medical College. MD in 1998 from same medical college. He was instructor in 2013 American Heart Association, New York. Postgraduate diploma in medical ethics and bioethics from Airway University, Mangalore. He completed in 2013. He has held various qualifications: coordinator for BSc, tutor, professor, associate, and PG resident. He is more interested, and his special interests are pediatric anesthesia, regional anesthesia, difficult airway, biotechnique, and medical ethics. Resource person in several national level difficult airway workshop, first aid association. So many credits he has. He has professional bodies like Secretary of Mangalore Anesthesia Branch and Secretary of Karnataka ISA. He was President of ISA Mangalore City. Senior Editor of Journal Anesthesia, Clinical Mangalore. So many things to his credit. He is a very dynamic person. He has guided 7 postgraduates in today. His publications are many. So with this, I present this great person to all of you. Thank you, sir. I request you to begin your lecture on perioperative coagulation disorders in pregnancy, which is very common nowadays. Please start.
Good afternoon, everyone.
Good afternoon, sir.
Thank you very much for this elaborate introduction, which is, I felt a little too exaggeration. Thank you so much, but anyway, for kind words. At the outset, I'd like to thank Vidya Madam and her team for this wonderful opportunity to be with you and talking on a topic which is always, I thought it's a bit difficult for any postgraduate, because pregnancy itself is a little bit of physiology intense, and over and above that, we have coagulation disorders superimposed. So I thought it is a little difficult topic. Anyway, let us see how it goes. And I appreciate the organization of this event. We had very good topics in the morning and excellent speakers. Dr. Ravindra, anyway, he's a wonderful speaker. He has recently written a book on how to make best use of residency. A wonderful book. I went through it. I think everybody can go through it and utilize the opportunity given as a resident. Then Dr. Madhuri also spoke very well about the ICU care. Now we are going to talk about perioperative coagulation disorders in pregnancy under following headings for about 45 minutes. is coagulation pathway, changes in pregnancy related to coagulation, coagulation tests which are relevant to us, coagulation abnormalities and management. Sorry for the spelling mistakes. Then finally, parturients on anticoagulants. Why this topic is important? As our chairperson already emphasized, the pregnancy and the cesarean section can throw a lot of surprises. One of them is patient till now doing very well and suddenly comes up with bleeding per vagina, atonic uterus, or abruptio placenta, or amniotic fluid embolism. Suddenly there is a 360-degree change in the scenario, and it makes everybody run helter-skelter to organize things. So I think we need to be very well educated, and the system should be primed to manage these situations where every second counts. Similar to what we practice during BLS or ACLS.
Excuse me, sir.
Yes, sir.
Sir, sorry to interrupt you, sir. Sir, can you please on the slide share option, sir?
Yeah, I have put on the slide share. I'm stopping the share. Yes, I stopped the share. I think I was seeing the slides. Anyway, sorry for that. I'm again sharing my slides. Are you able to see the slides now?
Yes, sir. Can you make it bigger, sir?
Sure,
Like,
sure. Yeah, are you able to see the slideshow? Hello?
1 minute, sir. It's taking time to load, sir.
Oh, no problem, no worries. Just let me know when it is ready. Just to continue, I was talking about we need to prime the system to work very efficiently in the event of emergency. Unlike routine surgical bleeding, or often we get orthopedic patients or RTA patients with the blood loss, many times we manage with a couple of pints of blood transfusion, a bottle or two of colloid and a bit of crystalloid. Obstetric bleeding may be really torrential. As such, the delivery is known to cause bleeding, cesarean section furthermore, and added to which we have any other bleeding that may really compromise the patient very quickly. Therefore, we have to have a good system, and the people around us should know how to respond to it with the adequate resources available at hand. That's why this topic is very pertinent, and the situation can rapidly change to worse. Sir, are you able to see the slideshow?
Sir, I'm able to see the slideshow, sir, but it's small. Can you please make it bigger, sir?
Yeah, second, give me a second. I'm resuming the slideshow. Is it again?
No, sir, it's not coming to full screen mode, sir.
Again, I'll go out. I'll go out and stop slide share. I'll again open the slide and sorry for the technical glitches, sir.
Sir, is it in Word format, sir?
No, it is in slideshow. I mean the PowerPoint one.
Okay, sir.
The PowerPoint.
The full screen mode is turned off, sir. Can you please turn it on, sir?
I am turning on. I'm coming to that. I put off all the. Screen. Sir, now are you able to see the slides?
No, sir. I am able to see the screen, sir, which you are sharing, sir, but not the slides, sir.
Switch options. Now you see, sir.
Yes, sir. Yes, sir.
Are you able to see?
Yes, sir. Yes, sir. Continue, sir.
Okay, thank you. So, are you seeing the changing of the slide?
No, sir. Actually, it's not changing, sir. It's still in the first page. Moving, sir. So did you change the page, sir, right now?
Yeah, now I am putting the first slide.
Okay, second slide, please, sir.
Now that's introduction.
Like, can you go to the next slide, sir?
Yeah, now
It's
I have
still,
put the next slide. I have put.
no, sir, it's still stuck in the first slide, sir.
This is a title slide, isn't it?
Yes, sir, the first slide, sir, the introduction part, sir.
I'm stopping again. Then again, probably I'll restart. 1 second. Now you just let me know,
Yeah,
sir.
sir, now it's in second slide, sir. Can you take to the third slide, sir?
Is it changing?
No, sir, it's not changing, sir.
Now I'm going to the next slide.
Third slide, sir.
Yes.
No, sir, it's still in the second slide, sir.
Now you see. Not changing.
No, sir, no. It's still in the second slide, sir.
Oh, very sorry for the delay. Now you see, sir. Now let me know.
Yeah, I can see the screen, sir. Your screen I can see, sir. But I'm not able to see the PowerPoint presentation, sir.
Still not coming.
No, sir.
I'm very sorry for the glitch.
No problem, sir.
On this. So I'm sharing the screen.
Yeah, sir. It came, sir. It's in the first slide, sir.
Now I'm going to PowerPoint show.
Sir.
Changing the slides. Hello, madam. Should I mail the PowerPoint to you?
The PowerPoint is visible, sir, but it's still in the first slide, sir.
Yes, madam.
Hello, sir. Sir,
Okay.
Yeah, now it's in the second slide, sir.
Sir, here is sir. Yes, sir. Sir. Sir, here is sir. Sorry. Laptop member la. The desktop. So I log in from another device.
Okay, sir.
Give me a minute's time. ಮೇಡಮ್ ಇಲ್ಲ ಒಂದು ನಿಮಿಷ ಪ್ರೊಜೆಕ್ಟ್ ಮಾಡ್ತೀನಿ ಒಂದು ನಿಮಿಷ ಜಸ್ಟ್
Yes, sir.
Hello, sir.
I'm
Can
able
you
to
see?
Yes, sir. I can see the slides, sir.
Okay, sir. Yes, sir. Can you hear me?
Yes, sir. I can. You are audible, sir.
Are the slides changing?
Yeah, yes, sir. Yes, sir.
Thank you so much. Sorry for the technical glitch. Due to the network issues, I chose to use a desktop. Probably that was the problem.
No problem. No problem, sir. Sir, please continue the lecture.
So we'll continue. Okay. Thank you so much for bearing with me. Now we are going to talk about coagulation disorders in a peripartum and perioperative period in the pregnancy. Actually, what we think about coagulation is slightly different from what actually happens in the body. We actually prime to think that there are two pathways to initiate the coagulation. That is intrinsic pathway and there is extrinsic pathway. This is what we learned from the days of physiology. And then they are together, they converge somewhere during the process of coagulation, and there is a final common pathway, and finally there is a clot formation and stabilization. But in reality, it is not very true. Actually, there is this is what actually we have been taught. There is an intrinsic pathway which starts with the activation of kallikrein and other factors which convert hegemon factor or factor 12 to factor 12, active factor 12, and it activates 11 and then 9 and 10 and like that. And there is extrinsic pathway which starts with the tissue activation factor, which is activated due to the tissue injury, and so on and so forth. And finally, the factor 10, that is the prothrombin factor, becomes activated, and thrombin is formed. However, in reality, it is not exactly the same. Reality is that it is a cell-based model where it is not entirely two different entities. There is initiation of clotting, and there's a rapid propagation of a clotting cascade, and there is a amplification and finally formation of a firm clot. Okay, you can see multiple clotting factors can be activated with the different stimuli at the same time, whether they are intrinsic factors or extrinsic factors. All of them can be activated simultaneously, and they are interrelated, as you can see here. And many factors are activated. Finally, the factor 7 and 11 and all that. And there is a small burst of thrombin formation, and it ends up in large thrombin formation. And finally, there is a intrinsic pathway which leads to activation of platelet, and platelets again come back to form thrombin, and clot stabilization takes place later. So it's a cell. In recent concept is that cell-based model where small thrombin burst with the tissue factor presenting the cell activates the cascade whenever there is endothelial damage. But there need not be always endothelial damage, or it may be because of some other reason. Then there is a large thrombin burst in the end, which leads to surface. It forms on the surface of the activated platelet, and then there is a formation of a thrombus. This is in brief. There is a small difference in the intrinsic and extrinsic pathway. Because of a time lag, I am going to be very fast. And then we also look at the different changes in the pregnancy which are related to the coagulation pathway. Similar to various organs which involved in changes in the pregnancy, there is also a change in the coagulation factors. That's most of the procoagulant factors like factor 1, 5, 7, 8, 9, and 10 all are increased, while factor 11 is decreased. And most of the procoagulant factors are increased up to 30%. And anticoagulant factors like protein S are decreased, while there is some of them are slightly increased, which resist the formation of the thrombus, because this balance is very much required. And there is one Willebrand factor which causes adhesiveness of the platelet, also activation of factor 7, which is very vital in the coagulation, which is also increased. And then fibrinolytic factors also slightly increase, but mostly the procoagulants are increased. And then microparticles on the endothelium and platelets also they are increased, which leads to increased tendency for coagulation. There is a list of changes with the percentage changes. So you can see here factor 7 is increased several folds. Even factor 7 and so on, they are all increased multiple times. D dimer is increased. That is because there is a rapid turnover of these factors in the blood. So then what happens to the coagulation tests when these changes are taking place? This is very interesting because we cannot compare the normal lab results during a normal person, and you do same test for a person who is pregnant and compare the basal values. There is an increased platelet count in many other situations, but in pregnancy it is not like that. In pregnancy the count may remain normal, actually it is decreased. And prothrombin time is shortened because there is a higher coagulability. And if it is more than normal, it is called prolonged in pregnancy. And if the platelet count is decreased less than 70,000 cells per cubic millimeter, then only it is called abnormal. Otherwise, it is not called abnormal. And there is a various list of the situations where you can see this. And similarly, there is activated partial thromboplastin time, which is one of the commonest tests done for testing the coagulation. It is shortened, and thromboelastography has got different changes. One is maximum amplitude is increased, range undefined because it's very non-specific, and reaction time is shortened. That's the initial reaction time is the K time is shortened in case of pregnancy, and differential diagnosis when there is a prolonged. The basic concept is now that these coagulation tests like PT-INR and APTT, bleeding time, clotting time, platelet count are the static tests. They don't tell you the dynamism of the coagulation, basically because they are essentially based on a particular pathway. or particular element of coagulation. But in reality, coagulation is a multi-dimensional. So many factors are activated simultaneously, and finally there is a formation of the clot including the the cellular elements of the blood. Therefore, now the traditional tests like PTINR and APTT are not much favored when you assess the coagulation, especially in pathological condition, when you have to do it on the go. Therefore, we have modern tests like thromboelastogram, thromboelastography, and Reorox G2, and there are many others. Are not listed all because they are not still available in our labs. Coming to traditional factors, that is the plasma factors, I already told mostly PT depends on vitamin K dependent, whereas APTT on other remaining factors. And turnaround time is very long, at least 1 hour from the time of the sample reaching the lab. Whereas the modern tests like TEG and ROTEM, they basically have a principle of either a rotating rod or needle in a container, or the container itself rotates. And as the thrombus forms, the threads formed by thrombus, the filaments formed by the thrombus are attached to the needle in the center. The needle is pulled, rotated, and this rotation is recognized and read and analyzed in of the TEG or ROTEM or Reorox G2. This is the most recent type of test. The thing is, they're all point of care. You can do it at the place of your intervention, and you can do whole blood, and the formation of fibrinolysis also can be tested, unlike in other tests where they only test the coagulation side and not the thrombolytic side. Then they also measure the kinetics of the clot formation at a various stage, what is happening, and the strength of the clot. This is also very important to have a stable clot, and they work at 37 degrees, which is actually body temperature. However, there's a limitation because it works at 37 degrees and the body is cooled to 35 or 30 degrees. At that point of time, what happens? You can't measure because you are warming the blood to the normal temperature. So hypothermia and its effect on the body cannot be measured. Whereas it is insensitive to factor deficiencies because other factors can make up for the deficiencies and you get a wrong result. And at the same time, or we may not be able to detect the presence of any deficiencies. Interventions may mask other lacunae like factor deficiencies, which if you give fresh frozen plasma, which is not having all the elements, but still it can say that the clot formation is good because some other factors has in the process. And also it is, you cannot extrapolate the results of this test to our anesthesia related procedures like say neuraxial block, where you have to rely on one particular function of platelet or something like that. So, and we don't have yet the adequate results for this to standardize something and go ahead like that. Again, we have other elements like platelets. We are not included in this discussion about modern tests. We have a platelet point of care tests like a platelet function. These are like platelet count, which is not functional. It only gives a static measure of the platelet numbers. And platelets are non-functional. There is a problem. But platelet aggregometry can actually identify the platelet aggregation speed and quantity. You can actually find out the function of the platelet, but it is a really time consuming. Whereas the platelet works, PFA 100 and multiplate and all these kind of new tests, they can actually dynamically measure the platelet function and not only quantity of the platelet. So even platelet disorders, platelet called thrombasthenia in say in neurological disorders or other hematological disorders you can identify. So also in the pregnancy, and effect of antiplatelet drugs can also be measured by these tests. However, the standardization of the results is not established in the perfusion, and more so for the central neuraxial block, which is always a matter of content for us. Then now routine coagulation tests are not recommended in the normal pregnancy unless you take a thorough history and say that there is a factor which can indicate that the patient may be having abnormal coagulation problem. So if suggestive, please go ahead with the test. Say you can go for a VT, CT, platelet count, PT, INR, and APT and so forth, whatever available in the lab. And also you can go for measuring the individual clotting factors if you suspect any abnormal. Then coming to the coagulation disorders in pregnancy, grossly we can divide them like this, classify them as a clotting factor abnormalities and platelet function abnormalities. Clotting factor abnormalities are again congenital and acquired. Any person who has got a congenital disorder who is a female can actually become pregnant, and the same problem may carry into the pregnancy, and they can acquire more such problems during pregnancy. And again, platelet function abnormalities can be quantitative and qualitative, like any other situation. Now coming to the examples for congenital clotting factor abnormalities, von Willebrand's, hemophilia A and B, antithrombin deficiency, whereas acquired may be pregnancy-induced hypertension, placental abruption, retained red fetus, amniotic fluid embolus, liver disease, it's called a fatty liver, and anticoagulants, aspirin, heparins, like that. Now coming to congenital, briefly I'll just brush up on congenital disorders in pregnancy because they are, though rare, sometimes you may come across them and you have to efficiently manage, because when you know the problem, you should be able to manage effectively without leading to any complications. Von Willebrand's disease is a very, of the lot is most common. It is autosomal dominant, so it manifests very clearly, so family history will indicate. And there is a factor 7 cofactor is deficient, that is called von Willebrand factor, which goes with the name of Mr. von Willebrand, who was a researcher who found the factor for the first time. It has two functions. One, it is forms of factor 8C, which is active factor, and then there is a platelet binding to the damaged endothelium, which initiates a formation of clots. Therefore, this it has got 3 types of deficiencies. So there are 1, 2, 3 types. One is partial deficit, only quantitatively it is less. 2 has got qualitative as well as a platelet deficiency, and there is an absolute absence of von Willebrand factor. That is a 3rd type with the factor also, factor 8 is also deficient. Now, in pregnancy, what happens? The von Willebrand factor increases in pregnancy normally several hundred times. So the type 1 is nicely improved, so you may not find any abnormalities, whereas a type 2 and type 3 will not improve because there is a severe deficiency. Desmopressin will help in certain cases, but may not help in all the cases. And also, von Willebrand factor concentrate definitely help in all situations. What about vaginal delivery? If the factor concentration is more than 40 international units per deciliter, you can go ahead safely with vaginal delivery. So for LSCS is about 50 international units. However, the problem is this factor rapidly decrease after the delivery of the fetus, because this is a normal phenomenon in the body, and during pregnancy it is already increased several times, and already deficient person, this may decrease further and may cause rapidly PPH. We should be aware of that. And there is not typical guideline for neuraxial block, so better go for general anesthesia. Type 1, yes, there's improvement to go for regional anesthesia, but remove catheter immediately after epidural and delivery of the fetus. Otherwise, there may be a formation of epidural hematoma. Better hurry and don't risk. Type 2 and type 3, don't go for central neuraxial block because there is a high possibility of bleeding and causing a clot or hematoma. Whereas X-linked hemophilia is females are carriers, but sometimes it can still manifest among females, and therefore the pregnancy it may sometimes manifest. It has got types A and B. A got a factor 8 deficiency, and B has a factor 9 deficiency. And again, it depends on the severity of deficiency. You can classify mild, moderate, and severe. And hemophilia A is factor 8 deficiency. Hemophilia B is factor 9 deficiency. Desmopressin can help in factor 8 deficiency, but not in factor 9, where you have to give factor 9 concentrate or fresh frozen plasma. So individual factor replacement is one of the best treatment for these diseases. Then theoretical risk of uterine contraction is there with the DDAP, the desmopressin, but it is advised in labor, nothing to worry about it. Then in hemophilia, go for platelet count, APT, TPT, NR. If they are normal, go for epidural, but remove the catheter as soon as possible. Same guidelines hold good. The unit have the assay of the individual factors. If the factors are more than 50, safe to give anesthesia and give central axial block, but remove the catheter as soon as possible. Now coming to clotting factor abnormalities acquired. In the pregnancy, we have several conditions where the coagulation abnormalities can arise due to pregnancy itself, because in the pregnancy there's hypercoagulable state. Any tissue damage can manifest in access to the vascular system to the tissue thromboplastin, which can trigger the coagulation cascade, activation of coagulation, which leads to widespread intravascular coagulation because it's highly thrombotic state. It is like you are having lots of cracker in your storeroom, and one spark goes and gets there, and all of them in no time get fired. Then there is a coagulation, and this coagulation consumes all the coagulation factors, and there is a bleeding, and you try to replace the volume with FFPs, sorry, PRBCs and the fluid, and so there is a dilutional coagulopathy and also consumption coagulopathy. So there is finally there is a deficiency of coagulation factors and platelets, leading to further bleeding. So this is common for almost all the acquired bleeding death is in the pregnancy. So what actually happens is there is acute traumatic coagulopathy due to tissue injury, or it may be secondary to the blood loss because of some other reason. Say there is a cervical tear, there is a when you do cesarean section, one vessel is opened and it bleeds continuously, things like that, or atonic uterus bleeding continuously leading to shock. So even shock may cause, if it's severe, the tissue injury and initiation of coagulation. So it can be either way. Either it is tissue damage due to, say, placental abruption or puerile uterus, or atonic uterus, or amniotic fluid embolism, or any of these. At the same time, it may be due to simple shock because of loss of blood. They follow additionally by iatrogenic due to resuscitation. That's you give a lot of fluid, you give certain coagulation factors, you don't give certain others. So there's a dilution, and there is a deficiency, imbalance, and then there is hypothermia, acidosis because of the environment, and shock and loss of consumption factors and consumption coagulopathy. So initially bleeding by tissue injury, it leads to coagulopathic bleeding. So there is a bleeding, and finally there is a shock. There is atony of the uterus because the uterus is not getting adequately perfused. There is hypothermia, acidosis, muscle is not in a good state to contract, atony, trauma, and placenta may be stuck there. So all leads to further bleeding, and it leads to severe problems. Then there may be other issues like liver disease, or fatty liver, or HELLP syndrome, abnormal platelets because of the pregnancy, and so forth. So finally, the management is very simple. One is the obstetrician is clear-cut job of controlling the surgical bleeding, and anesthesiologist has to correct other abnormalities like hypovolemia, hypothermia, acidosis, which is a very bad triad for coagulopathy, and correct the coagulopathy per se. So therefore, you avoid overloading the patient. You have to have goal-directed treatment plan. You should avoid colloids and supranormal blood pressure at any cost, and hemostatic therapy it's entirely directed to perfuse the tissues at the required level and not at the luxury. So you replace the labile factors like fresh frozen plasma. You can have stable factors like factor concentrates, and you can have cellular components transfused like a platelet target is about 1 lakh per cubic millimeter. And then you can also give antifibrinolytics to stabilize the clot, whatever is formed by aminocaproic acid and tranexamic acid. And remember, these things should start at the earliest. Whenever the bleeding is more than 500 ml and you look forward for continued bleeding, or bleeding has crossed 1000 ml and you see another little bit of bleeding coming up, so please start intervene at this point of time, and you will definitely save this patient. It is there was a trial called Woman, that is a world maternal antepartum hemorrhage trial. It was published in Lancet, one of the very good trials. It found that tranexamic acid can make a big difference if it is given first 3 hours of initiation of the problem, so that
the 30% of the lives could be saved just by using 1 to 2 grams of tranexamic acid in time. So even with the PPH or a history of it, fibrinogen concentration should be determined as a fibrinogen factor concentration of less than 2 gram per liter may identify those at risk of increased risk of severe bleeding. So we have to assess fibrinogen as early as possible if you think that there is a bleeding diagnosis. And PPH progression will be halted if fibrinogen levels are more than 4 grams per deciliter at the initiation of the event. So we have to make sure that we infuse adequate fibrinogen if you detect there is a problem. But there is no role for preemptive fibrinogen infusion. However, this trial was not very well calibrated to know the effect. They did intervene among the patients who were having fibrinogen level of 4.5 grams per deciliter, sorry, per liter. Therefore, the outcomes are not valid at that stage. And also remember to optimize the ionized calcium level. It is ionized calcium and not the total calcium in the serum. You have to take an ABG and you get, if the ABG is properly calibrated and if you have pre-heparinized syringe, you get ionized calcium value. Please keep it above 0.9 millimole per liter. If not, you give calcium chloride preferably. If not, then you can give calcium gluconate 3 times. And most important, if you suspect whenever there is a peripartum bleeding, intraoperative or vaginal delivery, first thing, there should be very low threshold for calling for help. So you can categorize if you want to say ongoing blood loss more than 500 ml. Already 500 ml of blood is lost and it's going on. Further, you please call for help and you have better team to work with. Then second is whether vaginal or cesarean delivery, never mind. If the bleeding is more than 1000 ml, it is a time to act now and call for help, especially when the bleeding is more than 1500 ml. Press all panic buttons and get as much as help as possible so that you can manage the patient at the best. So when the PPH crosses 1500 ml, you should make sure that patient gets supplemental oxygen and oxygen preferably delivered by mechanical ventilation to reduce the body requirement for oxygen and perfusion. And change regional anesthesia to general anesthesia because the regional anesthesia is going to adversely affect the hemodynamics of the patient. And quickly secure 2 16-gauge cannulae. Central cannula is a must in this situation. Arterial line, if possible, should be secured, and real-time monitoring of the hemodynamic parameters is very essential at this point of time to get a good assessment of the patient condition. These are all general principles. There is no exception for rule in this case in any peripartum or perioperative bleeding in this case. Finally, you should always have a goal-directed resuscitation. Never go for high BP. Don't perfuse once the extraction is done. But if the extraction is not done, baby is alive and inside, maximize the perfusion till baby is extracted, because fetal perfusion depends on mean arterial pressure of at least 65 millimeters of mercury. And if once baby is extracted, just stop aggressive resuscitation. Target a hemoglobin of 7 grams per deciliter or 7 gram %. And once every hemostasis is achieved, then you can target more than 7 to 9 grams of hemoglobin. Till then, don't go for aggressive transfusion of RBCs and things like that. Targeting very high hemoglobin percentage till baby is delivered. Yes, we have to maximize oxygen delivery to the fetus for fetal survival, but not after that. Then permissible hypertension and restrictive fluid infusion are the motto of this management. Then what we forget most of the time is once hemostasis is achieved and within 24 hours, we have to think of possibility of thrombotic episodes following up, because this is a very pro-thrombotic state and whole system is now changed and thrombosis is very, very likely. Therefore, pharmacological thromboprophylaxis is a must. Now coming to individual situations like placental abruptions. Placental abruption is a premature separation of the placenta, either in a labor or even before labor. After 20 weeks of gestation, patient will have a pain abdomen, there may be vaginal bleeding or there may not be vaginal bleeding, or there is a tenderness on the abdomen. Usually there is some amount of vaginal bleeding. There can be both components, internal bleeding as well as external bleeding. Sometimes external is more, sometimes internal is more. When internal is more, it is more dangerous. It can cause two problems. One is concealed hemorrhage. You don't know the situation of the patient. Second, it can get through the uterine musculature and cause puellar uterus, and it will precipitate the DIC, which is very dangerous. So there can be two kinds of hemorrhages, concealed and revealed. Revealed, you see paravaginal bleeding, and concealed you can't see, and it leads to tenderness, pain, and vaginal bleeding. This is a deadly triad of placental abruption, which leads to shock, and it can lead to disseminated intravascular coagulation, which is a dreaded complication of any pregnancy with the complications. Then there can be growth retardation if this happens in a pre-delivery stage, and it is more well contented circumscribed placental separation can cause growth retardation. If it progresses and severe separation causes fetal loss and premature delivery. Management is entirely depending on the patient condition. If there is it's very contained, very small abruption, then delivery can be conducted with a complete bed rest, wait for the maturity of the fetus. If not, emergent delivery of the fetus is the treatment for abruptio placenta. Here various goals have been summarized in this chart. I'm not going to say again because most of these things I have already iterated at various stages of this discussion. Another important and much neglected condition is acute fatty liver of pregnancy, which is as common as 1 in 10,000 pregnancies, or maybe less, 8,000 pregnancies. Not many times they are diagnosed because the symptoms are very vague. It is abnormality, the beta oxidation of fatty acid in mitochondria. You can see that all the cycle is written there, and it produces medium chain fatty acids and metabolites, which cause problems with maternal circulation. There are lipotoxic metabolite accumulation, reactive action species, inflammatory pathways, and apoptosis, and all that. So they finally lead to liver cell damage and lead to vague abdominal symptoms like any other hepatitis. You get pain, you get a patient with the jaundice, vomiting and anorexia, dyspepsia, and all such things. And basically, there are vague abdominal symptoms till you see the jaundice. And once you see the jaundice, you can look at the liver and get a scan and find out there is a problem. And the tests generally reveal hyperbilirubinemia state and increased increased liver enzymes and elevated serum creatinine is very important thing to note. The kidneys are also involved in this condition, and later stage they may develop coagulopathies, and the final treatment for this condition is delivery. Just like a pregnancy induced hypertension, for this condition also delivery is the key. And it should be very well remembered that diagnosis of fatty liver of pregnancy is very, very essential at early stage, and intervention should take place very early, otherwise we are likely to lose the patient. However, for urgent emergent delivery of the patient fetus, neuraxial block has been successfully used, though there is a liver failure. INR of less than 1.5, definitely you can go ahead with the neuraxial block. However, there are certain articles still show that even higher INRs have no detrimental effect on the outcome of the neuraxial block. We are not very sure because very few supportive documents are available yet, instances are available yet. So we may have to further wait for more evidence, or you yourself may have to do some studies and give us data about this and evidence. Coming to the next acquired hemorrhagic disorders in pregnancy, is one of the important thing is abruptio placenta. We already discussed. The next is very important, is very dramatic, that is amniotic fluid embolism. Amniotic fluid embolism can happen anytime after 20 weeks of gestation. It can just simply spontaneously happen, but most of the times it happens either during delivery or during an intervention. It can happen through the placental attachment or surgical incision or cervical, endocervical veins. This is what happens whenever there is a patient with old age, trauma, abortion, or things like that, LSCS or instrumentation delivery. There is a possibility of development of excess pressure, which drives amniotic fluid into the cracks and crevices into the uterus, and it gets into the bloodstream, and all the products of conception, the fetal blood, the fetal amniotic fluid, which contains the hair, the cells, the proteins, everything can lead to severe inflammatory response, and it can cause severe respiratory vasoconstriction and the ARDS like picture. So there is a gas exchange problem, and there is high increased pulmonary vascular resistance, which leads to cardiorespiratory collapse. The manifestations include sudden shortness of breath, skin discoloration, cyanosis, tachycardia, hypotension, then chills, sudden onset of chills and fever, vomiting, severe anxiety, trembling and sweating and all that because of the hypoperfusion. And these are the manifestations. I'm going a bit fast because our topic is about disorders of coagulation, not about the manifestations of amniotic fluid embolism. But it is very important to suspect when there is a dramatic change in the picture of the patient who is a parturient or awaiting delivery. You should first think of amniotic fluid embolism because it is so dramatic and so rapid to worsen. Very immediate intervention can only save the patient and the fetus. So there is severe hypoxia and ARDS because of the severe transient pulmonary vasospasm, and there is a right ventricular failure because of the increased pulmonary vascular resistance and right ventricular load. What happens when the elements enter the bloodstream? They activate the platelet activating factor 3, then tissue necrosis factor, interleukin 6, 1, phospholipase A2, and endothelin, plasminogen activators, thromboplastins, complements, everything is activated at once, like in a big thrombinoblast. Coagulation cascade is activated, and you know that once the coagulation cascade is activated intravascularly, the protective mechanisms come into picture. That fibrinolytic system becomes activated, and both of them cancel out each other in the end, ending up all the resources available for clotting. So consumption coagulopathy at once sets in. Then there is also aggregation of platelets, another element. So finally, there is a widespread DIC. And diagnostically, there's nothing specific except that if you do fundoscopy, you see the bubbles in the retinal vessels, and when you auscultate, you may see a pansystolic high-pitched murmur of the tricuspid regurgitation of acute origin, secondary to increased pulmonary vascular resistance and dilated RA. So one of the best diagnostic tools is echocardiography, either transthoracic or still better TE, but patients should be stable to have this much time to go up with this diagnostic tool. You may see right ventricular dilatation, hypokinesis of the right ventricle. You see the right ventricle overload. There's a tricuspid regurgitation, right atrial enlargement, and there is a bowing sign. That is, you can see here interestingly, the right ventricle is dilated and the septum is peeping into the left ventricle, and left ventricular filling is reduced. As such, there is a reduced by blood flow to the left ventricle, and you can see some even thrombi giving the image at the apex of the ventricle also. This is called McConnell sign. So cardiac output is essentially reduced because of the reduced filling of the left side and in incapacity of the right side to pump blood across the pulmonary resistance. So what is the management? Management is very simple. Go according to A, B, C, D, E, like any other emergency. A for securing the airway, B for managing the breathing by effective ventilation with the maximum oxygenation to optimize oxygen saturation, and then intelligent fluid management. Manage the fluid. If hemoglobin is less, transfuse a good amount of packed cells along with the FFPs and other coagulation factors, and judicious use of vasopressor starting with the noradrenaline. Earlier concept of dopamine, I think now a given way to aggressive management with the norepinephrine or noradrenaline, but always consider dobutamine as a first line because it can give rise to some amount of vasodilatation in the pulmonary vasculature. Now, finally, what matters is acute resuscitation in the case of pulmonary embolism of amniotic fluid. Sildenafil, nitric oxide, and ECMO can help sometimes in improving the condition, improving the oxygenation of the patient. Generously use packed blood cells, fresh frozen plasma, and platelets in 1:1 ratio, all three at the equal ratio, and consider cryoprecipitated and tranexamic acid very early in the resuscitation, because we know that if the fibrinogen level goes below 2 grams per liter, there is a outcome is going to be bad. And tranexamic acid is going to stabilize the clots and prevent further bleeding if given within 1 to 3 hours of onset of this problem. And recently, there is some evidence to say that rivaroxaban and ketorolac or ondansetron given early can actually stop the process of widespread thrombosis and bleeding. Now, my request to the organizers is, if I am exceeding the time, please let me know so that we can wind up on time and will not disturb the schedule. I'm going to take another 10 minutes more if you let me do so. Yes, sir. Thank you. So last part of it is a platelet function abnormalities, a very important thing which is always a hard nut to crack, because there is no definitive guideline in managing these things. It can be both quantitative and qualitative. The three main important causes in pregnancy are hypertensive disorders like preeclampsia, gestational thrombocytopenia, and idiopathic thrombocytopenic purpura, which is already existing. These platelet function abnormalities can be either quantitative or qualitative, as all we know that. Gestational thrombocytopenia and thrombocytopenic purpura are quantitative problems. Number of platelets are reduced. However, whatever platelets are available, they are good quality. So therefore, you can safely manage these cases if you have a target platelet number, say 80,000 or 1 lakh per cubic millimeter. We are very happily placed. Whereas in case of qualitative problems, and when it is combined with the quantitative problem, you are at trouble. See, that's what, again, you classify static and dynamic problems. Static is at the beginning of the pregnancy or at 36 weeks, you have a certain count of thrombocytes, that is platelets, and you think, okay, 1 lakh platelets are there at 36 weeks, and after 1 week, patient has come for cesarean section, and diagnosis is idiopathic thrombocytopenic purpura. I think you are safe to go ahead with cesarean section under spinal anesthesia, because they are static conditions. The things don't change much. Whereas hypertensive disorders of pregnancy like preeclampsia, eclampsia, and HELP syndrome, they are dynamic conditions. The things change within several minutes, and we need to be very careful to know that things can change, and we have to be on our toes to diagnose the recent change. They are very dynamic conditions, either quantitatively as well as quantitatively. See, platelet count can change very fast, so not more than 6 hours should be left for the next count. And if you have taken count as 8 hours or 10 hours before, please make sure that you get a platelet count, serial count, and just before your intervention, so that you are very, very sure that there is no problem with the platelet count and it's a quality. Then preeclampsia is one very peculiar situation, both dynamic and static situation, qualitative, quantitative situation. Microangiopathic endothelial injury is supposed to be the primary cause of preeclampsia, with the formation of multiple thrombi, which leads to aggregation of the platelets and consumption of the coagulation factors, when it leads to bleeding tendency. So when it is associated with the liver damage, there is hemolysis, elevated liver enzymes, and low platelet count. This is a syndrome called HELP syndrome, which is a very favorite question in the exam. Then there is a liver dysfunction, obviously. Over to coagulopathy is there, and together they really cause a big problem for the management of the patient. Now you have a patient with HELP syndrome. You want to terminate the pregnancy at the earliest. Now how to go ahead? Okay, now there is no definite guideline to say that you have to stick to this numbers and this the quality. So what we can do is serial counts, and now say half an hour back you got a count saying that from 1,60,000 the count has come to 1,20,000, and now I am giving spinal. Okay, very fine. You go ahead with the spinal because you are likely to be on safer side. But we should be getting just before placing an epidural, so that we are very sure that at this point of time there is no immediate formation of hematoma in the epidural space. No, never forget to check the APTT at the same time, so that you can be really safe about quality, quantity, and the progression of the clot formation. However, there are some articles which some authors which say even a count less than 80,000 is sufficient to maintain the hemostasis when you do neuraxial blocks. However, the advice is that don't go by all these guidelines. Better be stick to a lowest level of 80,000 platelets per cubic millimeter, because there is a qualitative defect also in this. And the guidelines or the consensus say that we should go for soft tipped catheters if you want to put epidural catheters, so that shearing of the epidural veins are prevented, and go with the midline approach, not lateral approach, as far as possible. Minimum concentration of local anesthetic to be used to know whether the neurological function is intact, or if there is any problem with the neurological function, it is to be detected at the earliest. Then keep assessing the motor function every hour, at least in 2 hours, till the catheter is removed and residual neurological pocket is worn out. So then, if there is a disproportionate block, you have used 0.265% bupivacaine with the, say, fentanyl of say 2 microgram per ml, and after 4 hours, you find that the lower limbs are densely anesthetized and they're not moving, or the duration of this block is taking longer than 2 or 3 hours, and say, okay, now your block is too good for the patient. No, then it is not really a good thing. Then you have to suspect there is a problem, immediately evaluate the neurological status, shift the patient for MRI and get a picture for epidural hematoma. If there is an epidural hematoma, the best result can be obtained if you evacuate the hematoma within 6 to 12 hours. It's very important. Otherwise, there may be permanent neurological deficit and we may be in the greatest trouble. So the last part of this discussion is parturient on anticoagulant. There are few instances where which I have listed here, like protein C and S deficiency, anti-phospholipid antibody syndrome, and so on and so forth. Some of them are not common, but anti-phospholipid antibody syndrome and protein C and S deficiency are a bit common. They have a tendency for coagulation, and pregnancy itself is a procoagulant state. Therefore, there is increased need for thromboprophylaxis in these patients. However, there is no direct complication of this disease due to neurological, neuraxial blockades or things like that. However, the treatment may pose a risk to the patient. So, the treatment is generally with the low molecular weight heparin or unfractionated or ultra fractionated heparin. It can be both. So we need to be careful about our timing of the intervention and know the drug exactly. If you are using low molecular weight heparin, no lab testing is required unless you are in a hurry to intervene. If it is enoxaparin, if the 12 hours is elapsed since prophylactic dose or 24 hours elapsed since therapeutic dose, you are safe to go ahead, and ensure that you restart the agent only 4 hours after the catheter is removed. Don't forget to get other tests in case of ultra fractionated heparin or plain heparin and time is not elapsed. Lab testing for its condition, if the ultra fractionated heparin is used for more than 4 days, we have to take a platelet count and also APTT to be sure that there is a adequate coagulation function. Also remember that nowadays patient can be on dabigatran and rivaroxaban. By the grace of the Chinese, we have now COVID-19 pandemic still on, and we see a lot of the residual effect or sequelae, and one of them is procoagulant state among the patients suffered COVID-19, especially with severe COVID-19, and they may be on these oral anticoagulants which inactivate the factor 10 activation. And you should remember that if they are on them, the intervention should be 5 days after dabigatran stopped and 3 days after rivaroxaban is stopped. And so that case, you don't need to test any coagulation factors on any coagulation states. Otherwise, you have to be very wise and better avoid the intervention. If not, you go for PT, INR and APTT, though they are not very specific to this condition. Coming to the conclusion, pregnancy is a prothrombotic state, everybody of us know, and the various dynamics of the pregnancy and delivery and surgery, that is LSCS, can intervene at the various stages of coagulation cascade. Therefore, coagulation can be really affected by peripartum issues leading to acute peripartum hemorrhages, which is complicating the situation and may lead to bleeding diathesis, or the pre-existing bleeding diathesis may complicate the situation. Then we don't have clearly set guidelines for using central neuroaxial blocks, which is most preferred for labor analgesia and delivery. So we need to be very cautious when we proceed with the adequate knowledge and assessment of the patient. Then it is always a local protocol which helps you more than going for international protocol, because the tests available, the medicines used, and the knowledge as well as the lab backup is all limited because of the local factors. So we have a local guideline for you to work. Then it is a dynamic interdisciplinary management always. You need to have a good blood bank and a massive transfusion protocol in place, which can be activated as and when required. I have not spoken about it because it is already, we have consumed so much time. We should not become a thing like consumption coagulopathy, nothing left to the next speaker. Then you can utilize the new point of care tests like the TAG or the ROTEM or the new RORAX and all that. The tests are coming, though they are expensive in the beginning. I think a matter of time now with the hackathons coming up. We had recently Netta Healthcare Hackathon, where new devices were formed. Similarly, in India, within no time, we may be able to get this at a low cost. So I think point of care tests for coagulation and fibrinolysis and all that will be of wonderful advancement in managing these peripartum hemorrhages. And I again thank from my bottom for your patience, audience, and an opportunity to be with you. It is a wonderful experience preparing for this talk and sharing whatever I prepared for you. Now, if there is time, we can have questions answered at the best of the capacities. Thank you so much.
Thank you, sir, for your nice explanation. You made this difficult topic an easy one. I hope everybody has understood. Now, topic is open for discussion. If anybody has questions to ask.
Good evening, sir. I have one question, sir. Any coordination between patients developing DVT in femoral satellite catheterization in obstetric patients?
Sir, can you please repeat the question? I got heard that DVT.
Yes, sir. Sir, in obstetrics patients, sir, is there any correlation between when we are securing central line patient developing of a DVT chances?
Do you mean to say that because of central line patient is developing DVT?
No, sir. When we are securing central line, is there any chance to develop a DVT, sir, in obstetrics patients? Chance of developing any DVT, sir?
Again, the question is where do you secure the central venous line?
Femoral, sir. Femoral.
Femoral, okay. Yes. Yeah. Okay. If you say that you have secured a central venous line in a femoral vein, which is not uncommon, you are causing stasis at the lower limb, and that can lead to genesis of a thrombus, because Warkos triad says one of the important factor for the thrombus formation is stasis of the blood. But logically thinking, unless we have a thrombus formation around the central venous catheter, it's unlikely that we intervene with the flow in the femoral vein, which is quite a big vein and quite deeply situated. So, but it is not unknown that femoral catheter has not caused a thrombus and problems with the distal limb. It is a possibility. Definitely, yes, can't be ruled out. But it may not be so common.
Thank you.
Thank you.
Thank you, sir.
Thank you, sir, for your wonderful lecture.
Thank you.
Now I call upon Dr. Ramesh Sajna sir to hand over the certificate to Dr. Pandit Dhyaneshwar sir for chairing the session.
Now we call upon Dr. B.G. Tadipoti sir, the former HOD and professor of the Department of Anesthesiology, to chair the scientific section by Dr. Vijayapura sir, associate professor of the Department of Anesthesiology, on the topic anesthetic management of non-obstetric surgery emergencies during pregnancy.
Dr. Vijay Katti, fortunately he happens to be alumni of this college. Completed UG as well as PG in this college only. That is really given for this college here. And he joined as a lecturer on presently is working as an associate professor in the Department of Anesthesiology. He was a PG examiner as well as he guides on last year. We have a class obstetric anesthesia and neurology. So I hand over to Dr. Patil sir. Please.
Thank you, sir. Good afternoon. At the outset, I would like to thank our beloved HOD, Dr. Vijayapura madam, for giving me opportunity to be part of this CME. My topic is anesthetic management of non-obstetric surgical emergency during pregnancy. I'll be telling in this following heading: introduction, maternal and fetal aspects, physiological changes during pregnancy, timing of surgery, anesthetic management, pre-anesthetic visit and pre-medication, drugs, important side effects and anesthetic implication in pregnancy, conduct of general anesthesia, conduct of regional anesthesia, facts about anesthetic drugs and risk factors of drugs and pregnancy. Introduction. On an average, around 1 to 2% of pregnant women undergo surgery for non-obstetric conditions each year in United States. The most common surgery during pregnancy is acute conditions like appendicitis, cholecystitis, trauma, abscesses, emergency laparotomies, surgery for ovarian cysts, surgery for maternal malignancies, cervical encerclage, and surgery for bleeding from the aneurysms. The main risk of surgery during pregnancy include fetal loss, premature labor and delivery, which can result from both the disease process itself and the interventions. And anesthesia provider must provide safe anesthesia to the mother while minimizing the risk of developing side effects to the fetus. Whenever we are anesthetizing a mother, we have two concerns. One is maternal concern and second is a fetal concern. So maternal considerations are: it is important to understand the physiological changes of pregnancy and its effect of drugs on the mother. Maternal physiology changes rapidly from first trimester because of increased hormonal effect and increasing progesterone produced by the placenta. There is 20% increase in the metabolic demands in the second trimester and third trimester. The mechanical effects of the enlarging uterus seen in the third trimester. Fetal concerns are Safety of the fetus depends on the placental transfer of the drugs. All the anesthetic agents like benzodiazepines, opioids, induction agents, all these drugs cross the placental barrier. Only muscle relaxants and glycopyrrolate do not cross the placental barrier. And during anesthesia, we should avoid maternal hypoxia. Maternal hypoxia leads to uteroplacental vasoconstriction, reduced uteroplacental perfusion, fetal hypoxemia, acidosis, and ultimately leads to fetal death. And we should also avoid maternal hypercapnia, which may occur during spontaneous ventilation, the deep levels of anesthesia, and which lead maternal hypercapnia results in respiratory acidosis, uterine vasoconstriction, and reduced uterine blood flow. Maternal hypocapnia should also be avoided, which causes vasoconstriction and a shift in maternal oxygen hemoglobin dissociation curve to the left, resulting in decreased oxygen delivery to the fetus. Excessive positive pressure ventilation leads to maternal hypocapnia, should also be avoided. Maternal hypertension of any cause should be treated immediately and promptly. Before undertaking any procedure, we should infuse the ringer lactate 10 to 15 ml per kg body weight. It should be preloaded, and during conduct of anesthesia, if there is a hypotension, it should be treated immediately with ephedrine 5 to 10 milligrams and phenylephrine 10 to 20 microgram. And you should also avoid hypertonicity of the uterus. Now we should, before understanding, we should also understand the pregnancy is associated with physiological changes in almost all the systems. Pregnancy is associated with increase in the concentration of progesterone and increase in the concentration of estrogen, which leads to various physiological changes. There is increased activity, renin activity, which results in the retention of sodium and water. There is about 1000 milliequivalents sodium will be retained at term, which also results in retention of water. And at term, there will be retention of 7 to 10 liters of water in the plasma. And plasma volume begins to rise in the fourth week of pregnancy. And there is a 10 to 15% increase in the plasma volume by 6 to 12 weeks of pregnancy, and it reaches to 30 to 50% by 28 to 34 weeks of pregnancy, and yet it remains normal. And the average blood volume in non-pregnant patients is around 65 to 70 ml, whereas the average blood volume in pregnant women is around 100 ml per kg. The cardiac output start to increase by 15% by 8 weeks of gestation, and cardiac output increases to 50% by 28 to 32 weeks of pregnancy. Cardiac output increases, there is a further 20% increase in the cardiac output during first stage of labor, and 50% increase in the cardiac output during second stage of labor. Cardiac output decreases to pre-labor level in 24 to 48 hours after delivery, and cardiac output returns to pre-pregnancy level in next 12 to 24 weeks of in the puerperal period. Twin pregnancy is also associated with 20% increase in the cardiac output compared to single pregnancy. So the various physiological changes are: there is increase in the blood volume by 35 to 40%, plasma volume increases to 50%, red blood cell volume increases to 20%, the plasma volume increases is around 50%, and red cell volume increases 20%. It leads to physiological and dilution of physiologic anemia during pregnancy. Cardiac output increases to 40 to 50% at term. Stroke volume increases to 30%. Heart rate increases 15 to 20%, and femoral venous pressure increases to 15%, 15 millimeters of mercury, and total peripheral vascular resistance decreases to minus 15 millimeters of mercury. Mean blood pressure decreases to 15 millimeters of mercury. Systolic blood pressure decreases to 15 millimeters of mercury, and diastolic blood pressure decreases to 10 to 20 millimeters of mercury, and there is no change in the central venous pressure. These physiological changes have some anesthetic implication. The blood volume increases in the beginning from 6 to 8 weeks of gestation, to reach a maximum increase in the cardiac output by 20% by mid third trimester. Increase in the intravascular, there is increase in the intravascular volume, there is increase in the cardiac output, there is a decrease in the peripheral vascular resistance, and then that is associated with presence of supine hypotension syndrome, and there is an elevation of diaphragm, due to enlarged gravid uterus. The apical impulse is shifted to the fourth intercostal space, lateral to the mid clavicular line. And on auscultation, there is accentuation of first heart sound, and with exaggerated splitting from the dissociated closure of the mitral and tricuspid walls. There is no significant change in the second heart sound. Sometimes you may hear third and fourth heart sound may be here. Fourth heart sound is heard in 16% of due to increased volume and turbulent flow across the walls. Benign grade 2 systolic murmur may be heard over the left sternal border. It may be due to mitral regurgitation or tricuspid regurgitation. The ECG changes are there will be a sinus tachycardia, there will be ST segment depression and T wave inversion in the left precordial and left limb leads. There is left axis deviation in the third trimester. Chest X-ray usually in pregnancy will not take chest X-ray, but it may show apparent cardiomegaly, increased left atrium size of the increase in size of the left atrium, increased vascular markings, straightening of the left heart border and pleural effusion. Two-dimensional echocardiography shows heart is displaced anteriorly and leftward. The right ventricle increases in size by 20%, left ventricle increases in the size by 10 to 20%, and there will be left ventricular hypertrophy. Ejection fraction increases. There will be mitral wall, tricuspid, and pulmonary walls are dilated. Usually, aortic wall, there will be no significant changes will be there, and there can be tricuspid regurgitation or pulmonary regurgitation will be there, and there won't be aortic insufficiency. If aortic on echocard, if there is a aortic wall insufficiency, it is always pathological. Coming to intravascular volumes and hematology. Intravascular volume increased due to changes in the renin-angiotensin-aldosterone system, sodium absorption and water retention. There is increase in the plasma volume by 40 to 50% is relatively greater than that of increase in the red cell mass, that is 20 to 30% results in dilutional anemia. It's also called as physiological anemia of pregnancy. In immediate postpartum, there is again 30 to 40% increase in the blood volume due to auto transfusion of 300 to 500 ml of blood. There will be relative like leukocytosis. Pregnancy is a hypercoagulable state. There is increase in the increase in the fibrinogen level, factor 7, factor 10, and factor 12. There is a decrease in factor 11, 13, and antithrombin 3. Factor 2 and factor 5 are unchanged. There will be a slightly platelet count is slightly decreased due to hemodilution. It is termed as gestational thrombocytopenia. Prothrombin time and activated partial thrombin time decreases by 20%, and D-dimers levels are also increased. Systemic vascular resistance. Although there is an increase in cardiac output and plasma volume increases, systolic blood pressure decreases secondary to decrease in the systemic vascular resistance. Systolic blood pressure, diastolic blood pressure, and mean arterial blood pressure decreases by 5 to 20% by 20 weeks of gestation age, and gradually increases towards non-pregnant values as pregnancy progresses. Diastolic blood pressure decreases more than systolic blood pressure. There is around minus 15% decrease in the diastolic blood pressure. Central venous pressure and pulmonary capillary blood pressure are unchanged during pregnancy due to increase in the venous capacitance. And whenever patient assumes supine position, the aorta cable compression is seen after 20 weeks of pregnancy. So supine hypertension, this is the supine hypertension syndrome is defined as decrease in the cardiac output greater than 15% and increase in the heart rate by 20 beats per minute. Clinical features are it presents as hypotension, sweating, pallor, nausea, vomiting, and femoral artery pressure is known as Hozier's. And in this first figure, we are saying the patient is in supine position. There is a compression of the inferior vena cava and the aorta. When we give 15% wedge below the right right buttock we give. There is you can in the second figure you are seeing the compression over the inferior vena cava and aorta are relieved. This will lead to increase the venous return and increases the cardiac output. Whenever we are giving regional anesthesia or general anesthesia, we should place 15-degree wedge below the right buttocks to prevent aorta caval compression. Anesthetic. So, what are the anesthetic implications of cardiovascular system changes? Increased blood volume will compensate for blood loss that occurs during pregnancy. But due to this increased blood volume, pregnant patient may not manifest signs and symptoms of hypovolemia, that is tachycardia, hypotension, oliguria, till about 1500 ml of blood loss has occurred. Reduction of stroke volume, cardiac output during GA and sympathetic blockade during neuraxial anesthesia can aggravate the supine hypotension syndrome. For neuraxial anesthesia, the Oxford position have found we should go Oxford position to prevent more separate spread of the drug and to prevent aortic caval compression. Respiratory system changes are there is upper airway changes. Upper airway changes lead to increased resistance and snoring. Increased concentration of estrogen leads to mucosal capillary engorgement. There will be nasal epistaxis and nasal intubation may be difficult. We have to select a smaller endotracheal tube that is 6 to 6.5 millimeters tube for endotracheal intubation, and Mallam putty score also increases. Thoracic cage increases, both AP and transfer diameter increases by 5 to 7 centimeters, and breast enlargement may lead to difficult laryngoscopy. Chest wall compliance is also reduced especially in the lithotomy position. The decrease in the vertical size of the chest secondary to elevation of the diaphragm leads to 25% decrease. Leads to 25% decrease in the expiratory reserve volume, which results in 15% decrease in the residual volume, and which results in 20% decrease in the functional residual capacity. And in pregnancy, there is 20% increase in the oxygen consumption due to increase in the basal metabolic rate. Combined with this effect, reduction in the functional residual capacity, rapid desaturation occurs during periods of apnea. In a fully pre-oxygenated healthy non-pregnant patient, desaturation from 100% to lower than 90% occurs in approximately 9 minutes of period of apnea, whereas in a healthy pregnant patient, desaturation occurs in only 3 to 4 minutes in spite of good pre-oxygenation, and in morbidly obese patients, desaturation occurs in less than 90 seconds. The rates of difficult intubation is around 3.3%, and rate of failed intubation is around 0.4%, which are 8 times higher than compared to non-pregnant patients. So various changes in the lung volumes and lung capacities are: inspiratory reserve volume increases by 5%, tidal volume increases by 45%, residual expiratory reserve volume decreases by -25%, residual volume decreases by -15%, and lung capacity, inspiratory capacity increases by 15%, functional residual capacity decreases by 20%, tidal volume also increases, total lung capacity is decreased by -5%, and in ventilation, minute ventilation increases by 45%, alveolar ventilation increases by 45%, respiratory rate also increases, dead space also increases by 45%, and respiratory mechanics, pulmonary vascular resistance is decreased by -50%. This is the figure showing. This is the first figure is showing lung volume, lung capacity in normal non-pregnant patient, and you can see lung capacity. Normal lung capacity is around 4,200 ml in normal non-pregnant patient, and it is around 4,000 ml in pregnant patient. Tidal volume is 450 in non-pregnant. It is 600 ml in pregnant patient. Most important is the residual volume, when functional residual capacity has decreased due to elevation of the diaphragm. Blood gases, pH in non-pregnant patient pH is 7.4, and in first trimester it is 7.4 to 7.4, and in second trimester it is 7.41 to 7.4. Partial pressure of option in partial pressure of option is in non-pregnant patient is 100, and in first trimester it is 107, second trimester is 105, and third trimester is 103. Partial pressure of carbon dioxide is 40 in non-pregnant, and it is 30 to 32 in first trimester, 30 to 32 in second trimester, and 30 to 32 in same, it remains same. And bicarbonate level in normal non-pregnant patient is 24, and in it gradually decreases in the first and second, third trimesters. Anesthetic implication of physiological changes that occurs during pregnancy. Mallampati classification worsens during pregnancy and more during labor. We should anticipate difficult intubation as the upper airway changes, enlarged breast and obesity. Smaller endotracheal tube and ramp position may be preferred for difficult scenarios. Avoid nasotracheal intubation. It leads to increased bleeding, decrease in the functional residual capacity by 20%, and increase in the oxygen consumption by 20% can lead to rapid desaturation during periods of apnea in spite of adequate pre-oxygenation. And there is increase in the minute ventilation, and low functional residual capacity results in faster denitrogenation and rapid uptake of inhalation anesthetic agents. Central nervous system changes, vertebral column, there is increased lumbar lordosis, decreased intervertebral spinous process is decreased, and there is a distension of epidural plexus of vein and increased epidural fat, which leads to decrease in CSF volume. And we should decrease the for spinal and epidural anesthesia, we should decrease the dose of local anesthetics by 25 to 30%. Cerebral blood flow is increased due to decrease in the cerebral vascular resistance, and permeability to blood-brain barrier increases. And there will be an increase in the threshold of pain due to increased plasma endorphins and progesterone. The minimum alveolar concentration of volatile anesthetic decreases by 30% during pregnancy, secondary to increase in the progesterone and increase in the levels of endorphins. Functional residual capacity decreases. There is rapid uptake of volatile anesthetic agents. Anesthetic dose requirement is also reduced. There is increase in sensitivity of opioids, sedatives, and local anesthetics. And there is a greater degree of dermatological spread. Spinal anesthesia, during spinal anesthesia, we should reduce the dose of local anesthetic by 25 to 30% because of increased neuronal susceptibility of local anesthetic to the progesterone. Epidural venous plexus is engorgement due to aortic wall compression, and CSF changes. There is a decrease in the CSF protein, which leads to increased concentration of unbound drug, and increase in CSF pressure. CSF pH leads to increase in unorganized form of drug. Pelvic widening and resultant head load tilt in left lateral position, causing greater degree of dermatomal spread. Gastrointestinal system changes, anatomical changes and physiological changes. There is separate displacement of the stomach and parallels, reduces the barrier effects. Intraabdominal pressure, intraabdominal portion of the esophagus becomes intrathoracic, and lower esophageal sphincter tone is also decreased. Gastric emptying is delayed in pregnant patient receiving systemic and neuraxial opioids. Aspiration of gastric contents results in chemical pneumonitis, which is called as Mendelssohn syndrome. There are two factors which are more important, that residual gastric pH less than 2.5 and residual volume more than 25 ml causes leads to severity of the aspiration. Patient should be given non-particle antacids 30 ml, 0.3 millimoles 30 minutes before induction of anesthesia if GA is preferred, and patient should be given pre-medication with H2 receptor blockers like ranitidine 30 minutes before induction, and metoclopramide 10 milligrams should be given. 10 milligrams should be given intramuscular route. Hepatobiliary system, the size of the morphology and blood flow, there is no change. Progesterone reduces the gallbladder motility, reduces emptying. There will be biliary stasis, risk of gallstones formation. Gallbladder surgeries or cholecystectomy is second most common surgery performed during pregnancy. Reduced plasma proteins will lead to increased concentration of unbound drug. Plasma concentration falls from 10th week up to 6 weeks in the postpartum period, but duration of succinyl choline is succinyl choline is unchanged. Renal system, kidneys, anatomical units are kidneys are both kidneys size and renal blood flow is also increased. Creatinine clearance and creatinuria increases. Reduced renal absorption leads to glycosuria and proteinuria less than 300 milligrams per deciliter. Isolated proteinuria more than 300 grams per 24 hours likely causes in preeclampsia. Endocrine system, increased GFR and increased renal clearance of iodine leads to decreased maternal iodine levels. Simultaneously, effect of human coronary gonadotropin leads to hyperplasia and thyromegaly. There is increased concentration of thyroid binding globulin, which leads to increased concentration of T3 and T4, but free T3 and T4 remains normal. There is a metabolic, basal metabolic is also increased by around 20%. Oxygen consumption is also increased by 20%. Musculoskeletal system, there is exaggerated lumbar lordosis is seen during pregnancy to compensate for change in the center of gravity caused by the uterine enlargement. There is stretching of the lateral cutaneous of thigh, which is termed as meralgia paresthetica. So in metabolism, BMR also increased by 15%. Oxygen consumption rate is also increased. Maternal tissue oxygen consumption is increased by 4 ml per kg body weight. Fetus, placenta, and uterus is in 12 minutes per kg per minute. Body weight and composition, average weight gain during normal pregnancy is around 10 to 12 kg or 17% of pre-pregnancy weight, and which accounts for uterus accounts for 1 kg, amniotic fluid accounts for 1 kg, fetus and placenta accounts for around 4 kg, blood volume and interstitial fluid accounts for 1 kg, fat and proteins accounts for 2 to 4 kg. Weight gain in non-obese patient, usually there is a weight gain of 1 to 2 kg in first trimester. In second trimester, weight gain will be around 5 to 6 kg. In third trimester, usually weight gain is around 5 to 6 kg. The factors which are associated with increased risk of anesthesia in the pregnancy are obesity, patients with facial and neck edema, patients with extremely short stature, that is height less than 140 centimeters, patients with difficulty in mouth opening, arthritis of the neck, short neck and small mandible, abnormalities of face, mouth and teeth, large thyroid, pulmonary diseases and cardiac diseases. These are the patients associated with increased risk of anesthesia. Timing of the surgery during pregnancy, this is very crucial. Timing seems to be very crucial for better fetal outcome. Decision of surgery requires multidisciplinary team. American College of Obstetricians and Gynecology recommends obstetrician and neonatologist should be consultation should be taken during the preoperative period, and they should be available in case of patient goes into labor. Overall miscarriage rate after surgeries are 5.8% has been reported, and overall rate of miscarriage increased to 10.5% if surgery is done in the first trimester. During the period of organogenesis between 3rd to 8 weeks, exposure to teratogens can cause major structural abnormalities. After this period, drug exposure can cause functional changes of fetal growth. So in the first trimester, all the surgery should be avoided. Only emergency and essential surgeries to be done during pregnancy. Best time to do surgery is second trimester. This is the chart showing surgical patient. Whether if surgery is elective, it should be delayed until postpartum period. If surgery is essential and if patient is in first trimester, If there is no or increase, there is no or minimal increased risk to the mother, consider delaying the surgery until mid gestation. If surgery is essential, it should be better to do it in second trimester. And emergency surgery, proceed with optimal anesthetic for mother, modified by considerations for maternal and physiological changes and fetal well-being. Consult perinatologist or obstetrician. Intraoperative and postoperative fetal and uterine monitoring should be continued. Suppose if patient is having most common surgery done during pregnancy for emergencies like acute appendicitis or cholecystitis, laparoscopic surgery is preferred than open surgeries. Previously, it was believed laparoscopy was not safe, but nowadays with reports are there, laparoscopy can be performed safely during second trimester. The advantages of laparoscopy are early mobilization of the patient, which decreases the thromboembolic events. There will be early rehabilitation and shorter hospital stay, lesser postoperative pain, decreased uterine manipulation and irritation, short return to normal diet. The risk of instilled hernia is less, lesser incidence of infections, and it has got better anesthetic result. Precaution to be taken during laparoscopy surgery are pneumatic stockings should be used to promote venous return, and lowest intraabdominal pressure should be used. 8 to 12 millimeters of mercury. You should keep intraabdominal pressure as minimal as possible. Aortocaval compression should be avoided by giving left uterine tilt. Changes in the position should be undertaken, and we have to closely monitor end-tidal carbon dioxide concentration, and we should keep PSO2 level within normal limits. Fetal heart and monitor should be done. Pre-anesthetic and pre-medication. Verbal reassurance is usually preferred to pharmacological pre-medication. Though examination along with careful, when we go for pre-anesthetic, we should carefully evaluate the airway. Possibility of miscarriage and preterm labor should be considered. The mother should be informed about the low risk of teratogenicity associated with anesthetic drugs. And the obstetrician team should be involved, and also the neonatal should be also involved in the team. And antacid prophylaxis is recommended after 14 weeks of gestation, and deep venous thrombosis prophylaxis should be considered. This is the chart showing drugs, important side effects and anesthetic implication in pregnancy. Inhalation anesthetic agents, volatile anesthetic agent, there is a decreased MAC, leads to reduced uterine tone and hypotension. Nitrous oxide, prolonged exposure may inhibit DNA synthesis, and it should be avoided in first trimester of pregnancy. Neuromuscular blocking agents, acetylcholine, reduced plasma cholinesterase, and there is possibility of prolonged action. Non-depolarizing muscle reactions are being quaternary ammonostructure. They do not cross the placental barrier. Local anesthetic drugs, reduced protein binding, increased risk of toxicity. Opioids, increased maternal sensitivity. Fetal withdrawal and intrauterine growth reduction is seen in chronic use. Non-steroidal anti-inflammatory drugs should not be given if it leads to premature closure of ductus arteriosus. Anticonvulsant drugs, warfarin is a teratogenic drug, crosses the placental barrier. Heparin does not cross the placenta. Anticholinergic drugs, atropine crosses the placental barrier and causes fetal tachycardia. Glycopyrrolate is preferred as it is a quaternary ammonium compound. It does not cross the placental barrier. Anticonvulsant, phenytoin, carbamazepine, sodium valproate, they cause congenital malformation or neural tube defects. Levetiracetam is considered to be safe during pregnancy. And AC angiotensin converting enzyme inhibitors leads to intrauterine growth retardation, oligohydramnios, and renal impairment. Diuretics like thiazides cause neural tube neonatal thrombocytopenia. Tocolytics, beta-2 agonists, riprodrin, terbutaline, salbutamol cause tachyarrhythmias and pulmonary edema. The oxytocin receptor antagonists like atosiban causes nausea, vomiting, and fewer side effects than beta-2 agonists. choice of anesthesia, always we should prefer regional anesthesia is preferred over general anesthesia because patient is awake, patient airway is not handled, airway reflexes are maintained, and polypharmacy is avoided, and there is decreased fetal exposure to provide fetal exposure of drugs, and it provides good post-operative analgesia. Routine monitoring should include pulse oximetry, ECG, non-invasive blood pressure, temperature, and urine output, and CTG, that is fetal monitoring should also be continued in the perioperative period. Conduct of general anesthesia. We should avoid aortic cable compression from 20 weeks of gestation, and by adopting left uterine tilt. Head-up tilt may be preferred, which increases the functional residual capacity, reduces the breast interference with the intubation, and elevate the gastroesophageal reflux. Airway management, mask ventilation, laryngoscopy, and intubation may be challenging due to increased weight gain, breast angle enlargement, and increased vascularization, which can predispose to bleeding during intubation. And whenever you are intubating a patient, all the difficult airway cart, emergency drugs, different size of laryngoscope, blade, supraglottic airway device, bougie airway, everything should be carried, and preferably 2 anesthesiologists are required during conduct of general anesthesia. A smaller endotracheal tube may be required. Equipment for difficult intubation should be available. Pre-oxygenation with a close-fitting mask for at least 3 to 5 minutes is recommended, as hypoxia develops very rapidly due to increased oxygen consumption, decreased functional residual capacity. Pregnant women are at higher risk of regurgitation, and aspiration prophylaxis should be given. Lower esophageal sphincter tone is reduced from early gestation, and intra-abdominal pressure increases from second trimester. So rapid sequence induction with precord pressure is recommended. Only once the airway is secured, ventilation should be aimed to keep PCO2 in the normal range. Pregnancy is associated with increased sensitivity of volatile anesthetic agents, with MAC values are slightly reduced. Volatile agents also reduce the uterine tone. Nitrous oxide is avoided in first trimester of pregnancy. Lateral planes of anesthesia, we should avoid lateral planes of anesthesia as it increases the metabolic catecholamines and releases, and consequently it will decrease the uteroplacental perfusion. Extubation should be done with patient is fully awake and preferably in left lateral position. Regional anesthesia is always preferred, highly desirable. Obesity, edema can obscure anatomical landmarks. Interspinous ligaments are hormonally softened, causing difficulty with epidural identifying the epidural space. The spread of local anesthetics within the epidural space are greater in pregnancy, and lower doses of for spinal and epidural, we reduce the dose by 25 to 30%. Facts about anesthesia drug. Usage of nitrous oxide during pregnancy can inhibit methionine synthesis, leading to problems with organogenesis. So it is better avoided in first trimester of pregnancy. Drugs increasing uterine tone should be avoided, including ketamine or local anesthetic agents. All commonly induction agents, opioid, neuromuscular blockade agents, and volatile anesthetic can be used pregnancy. They are not teratogenic when used in therapeutic concentration. Thiopentone or propofol are the commonly used induction agents. Neuromuscular blocking agents are generally ionized and do not cross the placental barrier. Plasma cholinesterase concentration is reduced by 35% in pregnancy, but there is no significant increase in the actual duration of with succinylcholine. Rocuronium can be used. Atropine may be preferred over glycopyrrolate as this muscarinic effect to reverse the muscarinic effects of neostigmine. Opiates. This is the risk category of drugs during pregnancy. They are divided into category A, B, C, D, and X. Category A drugs are these drugs are adequate. Studies in pregnant women have failed to demonstrate risk to the fetus. Examples are magnesium sulfate, thyroxine. Category B drugs are adequate. Human studies are lacking, but animal studies have failed to demonstrate a risk to the fetus, or adequate studies in pregnant women have failed to demonstrate a risk to the fetus, but animal studies have shown an adverse effect on the fetus. Examples are penicillin, erythromycin, paracetamol, lignocaine. Category C drugs are no adequate studies in pregnant women, and animal studies are lacking or have shown an adverse effect on the fetus, but potential benefit may warrant the use of the drug in pregnant women despite potential risks. These include morphine, codeine, atropine, corticosteroids, adrenaline, thiopentone, and bupivacaine. Category D drugs are there is evidence of human fetal risk, but potential benefits from use of the drug may be acceptable despite potential risk. These drugs are aspirin, phenytoin, carbamazepine, valproate, and lorazepam. Category X drugs, studies in animals or human have demonstrated fetal abnormalities and potential risk clearly outweigh the possible benefit. These drugs are estrogen, ergometrin. Post-operative care, thromboembolic disease is increased by post-operative venous stasis as pregnancy is a hypercoagulous stage. Prevention is by early mobilization, maintaining adequate hydration, TED stockings and calf muscle component devices are considered, and in high-risk patients, we should go low molecular heparin. Adequate analgesia is important and will cause increased circulation catecholamines, which will impair the uteroplacental circulation. Summary. Only essential or emergency surgeries to be performed, to be undertaken for non-obstetric cases. Only emergency and essential surgery should be taken in the first trimester. We should avoid elective surgeries. Best time to do surgery is the second trimester. Non-obstetric surgery during pregnancy is uncommon. Unless physiological changes of pregnancy need to be considered, especially the avoidance of aorta cable compression, antacid prophylaxis, and adequate pre-oxygenation. Airway should be properly evaluated, ensuring adequate maternal oxygenation and ventilation, avoiding hypotension, and avoiding drugs that increase the uterine tone. Perioperative fetal monitoring is essential. Regional anesthesia is preferred over general anesthesia wherever possible, and attention should be paid to thromboprophylaxis, analgesia, and signs of preterm labor in the postoperative period. Multidisciplinary team is essential. Elective surgery should be postponed until 6 weeks postpartum if possible. Non-elective surgery should be delayed until second trimester when organization has occurred and the risk of teratogenesis decreases. Thank you.
Thank you, sir. It was very nice. Clearly told all the knowledge about it. Many times we all come across that situation. You can see with some other. So it is not a clear message he has given to us. We all, I hope we all at least the knowledge so far he has imparted. Once again, thank you, sir. And it is open for discussion. Thank you, sir.
Thank you, sir. Now I call upon Dr. Nirmala Devi ma'am to give certificate to Dr. Vijay Katti sir for participant as a resource faculty and delivering a wonderful speech. Now I call upon Dr. Pratibha ma'am to hand over the certificate to Dr. D.G. Talikoti sir for chairing the session.
Now we come to the end of all sessions. This is really wonderful and an informative day. I thank all the faculty who had spent their valuable time and delivered a great lecture on different aspects of obstetric anesthesia. I would personally thank Dr. Vidya ma'am, Dr. Vijayapura sir, and Dr. Shivanand sir, who had taken a lot of strain to conduct the CME. And because of their continuous effort, the CME has become a big successful event. So thank you all. Thank you, ma'am. I also thank all the participants who were here and made the CME a wonderful event. And last but not least, this evening reminds me of Robert Frost, who told the words, words are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. Thank you. Thanks. I call upon everyone to take a group photo.